we're on, and we can actually see them too?
I think that'll be good. That'd be good.
We see you.
8 o'clock on the West Coast.
On the West Coast,
and,
11 o'clock here on the East Coast. Good times.
So in this course, the learning objectives that we have submitted on this is really review the underlying causes and risk factors contributing to meibomian gland dysfunction, Demodex blepharitis, inflammation, and corneal nerves in the ocular surface disease world, and again, how all that ties together. And identify diagnostic tools and technique used to assess the eyelid margin, the health, the inflammation, corneal nerve integrity, and examine current emerging treatment options for managing eyelid health, inflammation, or corneal nerve health, and develop strategies for the diagnosis and treatment options, really setting realistic goals for patients.
I think that last one's the most important.
You know, in anything we do, setting realistic expectations is so important.
It is. I mean, anything you talk about, you have to set an expectation. I mean, if you don't have where you're going, then how do you know how to get there?
You know, Mark, and that would include even letting a patient know that there are certain events that they could experience, and so that they're expected, as opposed to be considered in some type of a problem where they would discontinue
100%,
treatment.
100%. 100%.
Yep. And this disclosure policy by TFG Education that all the individuals in a position to control this activity disclose all the financial relationships. So these are our financial relationships.
Yeah, I want to see my financial relationships. See if I,
Is
okay.
that accurate?
Yeah,
Okay.
for the most part. Okay.
And you see mine, Mark's, Lindsay's, Mitch, and then Cory's as well.
Cory takes up a whole page.
And then, of course, Laura Straub with their, on the program and the relationships that she has as well, and all other Fundingsland Group planners and staff reviewers as well. So we're going to start off with a poll. And this is what the polls are going to look like. Rate your level of confidence in your ability to differentiate and classify ocular surface categories and disease severity, including aqueous deficient dry eye and corneal disorders.
All right, I am going to go with, I'm wavering between D and A. I'm not sure. Where you
we
at?
still get the numbers coming in, but we're really showing that most individuals that are answering this are somewhat confident in this.
So they're lying, is what they're saying. Yeah.
Well, just think how they're going to be after this course. Is they're going to be, we're going to raise that to very confident in that.
Yeah, 100%. Totally.
Another audience poll here. Rate your level of confidence in your ability to diagnose and treat patients with meibomian gland dysfunction. And again, we're looking at very confident, somewhat confident, not very confident at all, and not confident at all.
We hear a lot about MGD. Remember, Doug, when we first started practicing, and meibomian gland dysfunction wasn't even really something that you talked about or thought about. It was always just aqueous deficient.
In the first Deuce report, it wasn't even mentioned as a contributing factor.
Right.
And 10 years later, in 2017, it became of paramount importance because the realization.
Yeah. We were talking yesterday about that Delphi panel. We're not going to name names, Milton Hahn, Paul Karpecki, who were on that panel, where they basically said that the meibomian glands have no bearing on dry eye.
And
okay.
And one of the early pioneers really recognizing that problem was Dr. Don Corey.
Yeah.
And we were
Shout out to Corey
about that as well. So as we look at this poll, somewhat confident on this, and let's take a look at this. Rate your level of confidence in your ability to recognize the signs and symptoms of Demodex blepharitis. I think this is really important because of the awareness. Where are you going with this one, Mark?
So about 3 or 4 years ago, I probably would have been a D. I would have been, no, you know what? Don't really see the signs of that. I don't really hear the symptoms of it. I'm probably closer now to a C or a B. But I'm hoping, after listening to you, I'm going to be an A. Boom.
Mark, again, going back 3 years, I would have thought I knew the answer to this, and I would have been wrong.
Yeah.
I would have thought, I can identify, I can really have that, but then I would have been wrong, and hopefully we can pass that on today of making everybody the A-listers.
Yeah.
And we see right now it's kind of split, very confident, somewhat confident, not very confident, so we really have we got some work to do because we have
Yeah, come on, people.
24%
Stay with us.
that are-
Stay with us.
So let's talk about Demodex blepharitis, and I think that we're going to lead off with that. And really, I mean, what we see, it's probably one of the most common entities we will see within the practice. And this is where I would have been wrong. If I was asked a number of years ago, I would have said probably 10% of my patients really have Demodex blepharitis. And I would have been so wrong on that. And I think it took some of the studies to really, but I think more than the studies once they came out was the technique that you utilize to be able to visualize the collarettes.
Yeah, we'll talk about that in a second. I think what's really important, to me, the big takeaway on this slide is a couple things. One is the fact that where this data came from, I think, is important. So literally, I think it was like 1,100 patients, give or take, came in for an evaluation. It could have been IOP check, could have been cataract, could have been contact lens check. And simple questions like, do they have Demodex? Have they been diagnosed with dry eye? Do they wear contacts? Have they had previous surgery? And if you look at the numbers, I mean, 56% of these patients who had Demodex blepharitis had cataracts. And that kind of makes sense because, right, as we get a little bit older, we have a little bit of that overpopulation. But 60% of these patients were also being managed for dry eye. And I think to your point, Doug, about being wrong, I think we're going to see a really strong correlation between dry eye, or what we call dry eye, and Demodex blepharitis. But the next two, to me, kind of blow me away. 93% of the patients that were diagnosed with Demodex who wore contacts. You know, so if they had contacts and they had Demodex blepharitis, and I feel for us, especially as optometrists who are managing contacts, you know, we know what 40 to 50-year-olds, they start dropping out. We have to start looking for all those signs. And if you're not thinking Demodex, then you're really, really missing this highly prevalent, underdiagnosed clinical practice. I'm just reading the blue box right there. That's in your practice. And then 66% of these also have blepharitis. And we start thinking about blepharitis like meibomian gland dysfunction, or even just that anterior posterior blepharitis we talked about. So I think DB might be one of those things that for us is going to be kind of a turning point in the way we manage our patients, and we have more to come on that.
Well, in the study that you're referring to, that Titan study, it's important to realize that it was all comers. Anybody that was going, it could be a child, it could be an adolescent, it could be a senior. Anybody that came into an eye care practice on that day was evaluated based on those questions.
I actually, like yourself, I mean, I think I took 100 patients, went in, and I think I was like 70%. And it was not even on my radar. I just did not even care. I had no cares. I forgot I'm going to say something else.
You know, it's interesting. After doing that, you really realized what you didn't know.
Right.
When you.
Well, okay, for anybody here who's listening, Doug has always advocated. It's like, go into your practice tomorrow. Okay, tomorrow's Monday, and just test your patients, evaluate your patients, look at them, and you'll get a basis of all the things that you're missing because you're not looking for them. You know, it's 100% of your patients won't have something if you never do it.
Correct.
Totally.
Pretty good indication right there. So the key signs of Demodex blepharitis tends to be itching, but
Does it?
I think this is so important because you can ask your patient, do they itch? Do their eyelids itch? But sometimes they've adjusted their normalcy baseline.
Yes.
They've adjusted that where they're not even aware.
Yes.
I've had patients, actually, when I ask them that question, they reach up, they touch their eyelashes with one hand, they reach up on the other, and they say, no, I don't think I ever do that.
Yeah.
And I'll say, like you just did? And they'll go, oh, I guess the answer is yes.
I think, to me, if I was going to add something onto that, you know, symptoms would just be anything not normal to the eye. And what I mean by that is that, you know, you kind of like were originally thought if you itch your eyes this way, right? And kind of almost like horizontally on the lid versus rubbing your eyes. That's like a good indicator. To me, I think just asking patients, are you aware of your eyes? You know, is your vision fluctuating, as we see on there too? But I think the bigger thing is that the misdirected lashes, the increase you see in maybe rosacea or meibomian gland dysfunction, I think those are more common symptoms.
And if there's missing and misdirected lashes, there's something wrong with the lashes. And I think that's really what some of the others, and I do think it contributes to, or can, to blurred vision. and sensitivity to light in the more advanced type of
Advanced,
cases.
right.
But I really find, and someone who practices, ocular surface disease, really looking for that, it's a source of irritation, inflammation, and bacteria. I want to eliminate it.
Right. And I do appreciate the fact that you said practice, because you're still practicing.
Still.
Okay, you haven't mastered it yet.
No,
And that's
I'm still
a
working
beautiful
at it.
thing.
Still working at it, Mark.
Are we talking practice? So.
Rate your level of confidence in your ability to recognize the signs and symptoms of thyroid eye disease.
Oof. I don't know how loud that was for you guys, but that was a pretty big sigh here. I think I'm going to go with somewhat confident.
Somewhat confident.
Are you still practicing? Practice. Do you ever find that it sounds so weird that you're practicing?
Practicing. Yeah.
I mean, I guess, when do we ever master it? Never.
Fair enough.
Yeah, so I'm in my office mastering. No, you say practicing. That's weird.
So what we're finding is somewhat confident or not very confident. I think that's a very typical response that we have, just because there's been more awareness lately of thyroid eye disease because of the direct-to-consumer commercials on TV. So how many people come into your practice and they said, I think I have thyroid eye disease?
No, they don't. They say, I think I have TED. And I'm
Yes.
like, where? In your trunk? I mean, maybe you should let Ted out. And then I start thinking about that Mark Wahlberg movie. Is that the Ted we're talking about? Yeah. I don't think most patients even know what TED. Oh, there it is. There's TED.
Thyroid eye disease, TED. Most common orbital disease in North America and Europe, and frequently associated with Graves' disease. As we see, this often occurs with patients with hyperthyroidism on these patients. But, you get that patient, it has that certain look to it, that retraction of the eyelids. But really, this is a matter of treating the underlying systemic thyroid dysfunction with these patients as well. The interesting part is that all the patients don't come in looking like this.
No.
But it's,
Well, sometimes they do, Doug, when I tell them how much the Chrome Hearts are. What? Yeah. But, what's interesting, though, is that when you think about, TED, and we see here that, it's driven by an autoantibody activation of this insulin growth factor. So it's, the chemistry and the process behind this is a lot deeper than we realize. But for us, what we see is patients that have all of those classic dry eye symptoms. When you start thinking about, keratitis and inflammation and injection, but it's the underlying root cause is what we need to really kind of
Yeah, really, it's a ocular manifestation of a systemic disease that is occurring here, and that's where, in utilizing treatments and in looking at some of the awareness, again, of the direct-to-consumer advertising, I think that's really brought an awareness to patients.
Yeah.
And that's why, a lot of patients will come in with the dry eye and figure that this is a thyroid eye disease situation on this. Mark, talk about some of the key symptoms and incidents.
Well, I think exophthalmos is, one of them. We can call that bulging eyes, if you shall. When's the last time you did an exophthalmometry? Was it Hertz? Is it Hertz?
Yeah.
It hurts for me to
Hertel,
even
yeah,
think.
exophthalm.
Yeah, or to, it's so funny how many things we learned in optometry school that we just never do. Like fitting a contact. I mean, am I right? Right, Doug? But, inflammation, we start seeing that. It's literally, think about, just that exposure. We start seeing the evaporation on the eye, especially the tears. So all the things you think about, you see injection. Patients are going to have significant amount of discomfort, especially as it starts involving the EOMs. So it'll impair the vision, maybe the movement in the eyes. The interesting thing is about 3 in 100,000 people, are assigned male at birth have this, and then 16 of 100,000 who are assigned female at birth. So it's definitely a more female-driven, like almost 5 times more. But it's that inflammatory nature of this disease state.
And when you look at these type of symptoms, this is what you're going to find in a dry eye patient, with the exception of the exophthalmos. With these patients, the inflammation, the dryness, bloodshot eyes, pain, and impaired vision. So the 2 peaks of incidence usually occur between 2 ages, from 40 to 49 and 60 to 69.
Very interesting. Look at that, there's 2 peaks there.
Yeah, 2 people on there, yeah. And the pathologies of thyroid eye disease are optic nerve compression, where we get inflammation and fibrosis. So as this progresses, this can be a very sight-threatening disease that we see. Then that's going to lead that orbital compression is going to lead to extraocular muscles and diplopia. And then, of course, all the dry eye disease symptoms as well. But there's some other things, with diplopia that you find with that, and that's why this becomes such an imperative diagnosis to have, as opposed to dry eye.
I almost kind of feel like it's, especially even if you go back to DB, and correct me if I'm wrong, Doug, and everybody out there listening, but we've grouped everything under this dry eye umbrella, this tent, if you shall. And I remember for me, 30 years ago, starting to practice, and we used to classify anterior blepharitis, posterior blepharitis, and we had dry eye, and everybody, I think, everybody tries to fit all of these symptoms into a dry eye diagnosis without stepping back and saying, why is this happening? What is the underlying cause of it? And, for all intent and purposes, it could be a blepharitis. It could be more like a systemic condition like thyroid eye disease. It could be, neural, that we're going to talk about today too. So hopefully, we're all going to kind of walk away from this with a better understanding that it's not just put some lubricating drops on. We have to be a little bit more intellectually curious, if you shall. Yeah,
and it's true. I mean, we used to silo things, with patients into what their presentation was without really looking at the underlying etiology.
Right. Do you still, Doug, do aqueous deficient, mucin deficient, or lipid deficient? Do you still break your patients down that way?
Well, I will, because I feel that patients are on a continuum and they will develop different aspects of that as they go along. And I think certain patients will develop, say, a mucin deficiency or an aqueous deficiency greater or the evaporative cause, and really find out what the predominant is. But I really look at it as a continuum.
Yeah. I mean, I think I start with every living, breathing person has evaporative, and then go from there.
Yeah, go from that
seriously,
point. Yeah.
They all do. You do too. Those of you right now who are like simultaneously listening to us, but watching, scrolling, doing what you're doing, because we see you. I told you we can see you.
Rate your level of confidence in your ability to recognize the signs and symptoms of meibomian gland dysfunction and dry eye disease.
I want to know who the very confident is. There's a couple of people out there that just keep hitting very confident. I think they're just like, yeah, very confident,
Well, what we're seeing is somewhat confident and very confident on a very high percentage here, that we're almost up to 80% of that.
Wow, really,
90,
people?
90%, yeah. So.
Well, then, you know what? Then why don't you guys come over here, okay? Whoever you guys are. Shh.
Okay, let's talk about meibomian gland dysfunction.
MGD.
Art.
Yeah, love me some MGD. When we start thinking about meibomian gland dysfunction, you can see the scale there on the left-hand side where you start seeing the fact that we start seeing a low or lipid delivery system causes some hyperosmolarity. We also see in the slide here there's some obstruction, and then it also could be hypersecretory. You guys can follow through all the way down there when we start seeing the clinical signs of inflammation, more importantly, eye irritation, aberration of the tear film. I sometimes feel, Doug, we make things too hard. I mean, for me, meibomian gland dysfunction, the lipid that's coming out of there is basically, call it what you will. I call it the Tupperware, the lid on the Tupperware, the saran wrap, if you shall, to make those Rice Krispie treats stay nice and cool. I've heard it termed the roof. The roof is on fire. Let that thing burn down. No, the roof of your house, anything that's a protective layer is what the meibum is. And, if you look at these pictures here, there's not a single clinician here that's going to look and say, this looks healthy. You see the lid margin, you see the chemosis, you see the telangiectasias, you see the capped glands. I mean, it's
Mark,
not good.
in meibomian gland dysfunction, this is where I've really altered what I do in my exam, my slit limb exam, and that is press on those lids, pull on those lids, look for elasticity, but press on those lids. They had this phrase, non-obvious MGD, and it's only non-obvious if you don't press on the lids. Once you press on it, it has made itself abundantly clear.
I also think it's not obvious if you don't look for it.
Right.
I'm all about salt and pepper. I'm all about pushing it, pushing it real good. But I mean, I said to you a couple seconds ago that I go on the premise that every single patient that comes into our practice, nobody walks into the practice thinking, God, I love Doug Devries. He's amazeballs. Before he retired, he's not in the office today. Before he retires, I just want to spend as much time with him. No, they come in because something is telling them that something's not right. And I think collectively our profession has to step back and say, we are doing things different with our eyes than we did 2 years ago, 4 years ago, 10 years ago. And we're inducing evaporation. We're having such a bearing on a negative effect on the meibomian glands that why would you not want to do everything you can to help maintain those?
Really hit a turning point with the introduction of the smartphone.
100%, 2007, my friend.
Yep. 2007, and that's
We are
when
friends,
really started to see things change. And now, and I think just the pandemic then really amplified with everybody being online and Zoom meetings and
Totally. Microsoft Teams.
Microsoft Teams.
I hate Microsoft Teams. But can I just tell you, did I ever tell you about the time that I said to a patient, I said, all right, my friend, and she said, we're not friends. I'm haunted by her because honestly, I really did think we were friends. But every time I saw that woman, I'd come in and go, hey girl, and she'd be like, not sure why you're saying that. And then she just stopped coming to see me. Yeah.
Imagine that.
Yeah. All right, my friend.
You just can't predict some people, can you?
Seriously.
So let's talk about the role of inflammation and measuring that inflammation with measuring the matrix metalloproteinases.
You want to try that again, Doug?
Yeah, matrix metalloproteinases. How's that? MMP9.
MMP9. Yeah.
It's simply a proteolytic enzyme that is released by stressed epithelial cells. That's what happens when the epithelium gets stressed, is it releases MMP9. So the ability to measure that, even though it's a non-specific inflammatory marker, and it can occur if there is irritation because of inflammation, allergies, dry eye, epithelial basement membrane disease. So if something's wrong with the epithelium, it's going to secrete MMP9s.
So it's just a general indication that there's something not normal and there's inflammation.
Yeah, and it tends to be a pretty sensitive diagnostic marker, but like all diagnostic markers, it can have variability to it,
right?
And it matters how you test it and who's gathering that. But I find that MMP9 is a good way to indicate inflammation in that, and since that's one of the key components to dry eye disease with increase in osmolarity, increase in inflammation, and alteration of the surface that as we go on. I think this is a pretty important way to be able to. Do you measure MMP9s?
I don't. I'm glad you asked that, but I will tell you though that if there was a simpler way to do it, if I could integrate it, and I mean by integrating my practice, meaning that if the surgeon that I work with would actually get the device, then I would be using it. But I will tell you though that for me, anything that we can do to slow down the progression of the disease state. So when you start seeing indicators that you're moving into, a more upstream aspect of it, and I hate that term, but if we could try to stop things before they become more symptomatic. So measuring MMP9 and seeing that they're on the rise, I also think it validates to patients that, they're making a turning point.
Yeah, that's what I found was one of the biggest validations to patients as you're treating them, how they're responding, because they'll always ask, doing something like an inflammatory test where you're measuring that, and while you don't really quantify it, you essentially do quantify it by the redness that it has, and patients are very interested of how that looks and whether or not they're improving on that. And so I think that can be an important marker for several, validate the treatment that you're giving to patients, because we know some of the environmental factors that we have in creating and exacerbating dry eye. And I'm sure, being in Nevada, being in Arizona, patients will always tell you, well, I live here and that's why I have dry eye.
I hate that.
I know.
I totally. Can we put that slide picture up there? Understanding influential factors. Yeah. So what I hate is when patients say, well, come on, we live here in the desert. Okay, Doug, do you spend most of your day outside when it's 115? No, maybe floating in the pool. Mary, can I get a little touch up on my margarita? No, you know, most of us are kind of like inside. To me, I think it's drier in places where you see things like this, the atmospheric pressure, like, you know, up in like Denver area or on the East Coast where it's the winter time where it's cold and the air pollution is not great, you know, or there's construction going on and around the house. So you can't lose sight of those influential, you know, environmental
And to your point, I mean, you'd think, okay, it's going to be dry in Nevada and Arizona, but yet in Hawaii, it should not be dry. But yet they have an incredible incidence of dry eye because of the winds and because everybody is in refrigerated air.
Totally.
And they're very dry spaces. So, yeah, I face the same thing with it. It doesn't matter. And I'll say, you know, you might momentarily feel better if you get to a sea level or if you're on a cruise and you have that humidity, but you still have dry eye.
But I think the cruise thing is probably just jaded because most people are just drunk the whole time, right?
Their eyes feel better.
Not on Carnival cruises. They're hot because they don't have their fans anymore. Actually, they may have less dry eye now that they have a no fan policy in the car. Are you aware of that?
I wasn't aware of that.
Oh, but you know it now.
Thank you.
Yes.
I appreciate that.
Boots on the ground. Look it up, people.
But the influential factors of environmental, I mean, it plays a big part in exacerbation and even, you know, temporary admission as well.
Ooh, more audience polling.
Here we go. The following series of questions will help determine your level of comfort with diagnosis in eyelid margin health.
When do you use myography in the diagnosis of ocular surface disease? At the initial point of care on a case-by-case basis? Never. What is myography? And I don't have access. Oh, that's sad. Sad. Yeah.
And you see, you know, with live presentations, when you ask this question, that an increasing number of doctors have myography.
Yeah.
Because that 7-10 years ago, it would be
very little to
very
none.
little.
Yeah.
Very little.
Yeah. I think I'm going to go on a case-to-case basis. Where are you at on this?
Well, since I am practicing all with ocular surface, it's on every patient that I see at the initial visit.
Okay,
So
fancy pants. All right. Okay.
we take that. But, you know, and this speaks to, you know, the general population that 72% don't have access to the technology. And I guess that follow-up question is, would you like access to that technology?
Well, let's do a follow-up question. Would you like that? Just shake your head yes or shake your head no. Okay? We got you.
Rate your level of agreement with the following statement. It is not necessary to test osmolarity in my pre-surgical patients. Strongly agree, somewhat agree.
Necessary. Necessary is doing the heavy lifting to me.
It could be helpful as opposed to necessary.
So I'm going with B. Nobody put B. We're getting very lit, somewhat agree. Can I get somebody to click somewhat agree for me out there? Yeah.
There we go.
Oh, thank you.
Wow.
Thank you. Somewhat disagree. No, I want the people that strongly disagree. If you can go into the type chat in there, make your argument. Let's do this. Okay? We will fight you. Okay? Because how are you going to assess the ocular surface of a patient who it's so dependent with the quality of the surgery, post-operative results, is that if you have a crappy ocular surface, and osmolarity is probably the best indicator of that. Okay? And when you're thinking well, we'll talk osmolarity. I have my own ways of thinking about osmolarity.
And really what's made that more apparent than ever is several different types of IOLs, like a light adjustable lens where you have to have some kind of a stabilized surface to make the adjustment.
Or even something like the Apthera from Bausch Plus Lomb, which was, you know, it's the camera, where we see that kind of small aperture. If you're looking through a 1.38 millimeter and you have ocular surface or inflammation, they're looking. Yeah, strongly disagree. I want to hear. Bring it. Bring it.
In your practice, which method of gland expression is used? Manual, automated, both, neither. We don't express the glands.
I'm going with both.
I agree.
A lot of our audience is still doing just manual. Okay.
Both? Okay.
Yeah.
No,
never. We don't. Neither. I think there's a percentage of our attendees out there that are just kind of going, should have put the last one every time.
Well, and I think what we're in this question, we're not talking about diagnostic versus therapeutic expression.
Oh,
Because it could be diagnosis is manual. I would totally agree with that.
Yeah.
And almost everybody does manual because you don't use automated. But therapeutic then, and we'll kind of dive into that a little bit later of what that looks like. So I think diagnostic versus
I am so
therapeutic.
glad I didn't read these questions ahead of time. I'm glad I'm just like everybody else going, ruh-roh. Yeah, can somebody change my answer to that last one?
Yeah, we'll
Because
change
I'm
it.
going to just do manual.
Well, so noted.
Yeah, thank you.
During a routine exam, do you perform an eyelid margin exam?
I thought
That's a good one.
I thought it said during an eye exam, do you perform an exam? And I'm like, I will be performing Shakespeare. Yes.
Always? Often?
Okay.
Good.
Yeah.
Okay.
Yeah, that's good.
75%, 76% are saying always.
We're going to talk to the 24% that say often.
Often? Yeah.
Because imagine a patient who came in without eyelids. Just leave it at that.
Diagnosing Demodex blepharitis. Okay, we're going to talk about
This is challenging, Doug. I mean, we only had 3 hours, so we really had to condense how we talk about diagnosing Demodex. How do you tell a patient? What do you do?
Well, as part of my eyelid exam, or part of my slit lamp examination, number one, I always press on the meibomian glands. Want to find out whether or not they have any form of MGD and what the severity
You're jumping ahead. We have an MGD diagnosis.
Oh, okay. Well, but it's part of the
okay. All right.
It really is integral to the Demodex diagnosis as well. And then I have the patient look down. And when I say look down, I have them look down at the table.
Okay.
So I can see the root of the eyelashes. And then I'm simply looking for that little volcanic, that little collarette around there that is 100% pathognomonic of Demodex blepharitis. So that's what I do to really identify it. Now, the importance of looking at the meibum is we'll kind of cover that a little bit later in the treatment of that, that becomes imperative also if they also have a diagnosis of MGD.
I mean, it's interesting is that, again, things that you never think about, okay? And one of those things is literally looking for collarettes. I've seen collarettes my whole career, okay? And I would walk in and basically just see all this crap at the base of the lashes. And, we call them scurfs, or we call them
Debris
cylindrical dandruff, debris. But if you really look at the base, this is where it's coming from. It's that overproduction of just like debris, everything that you think about. Have the patient look down, pull up on the upper lid if you have to a little bit, turn the mag up just a slightly bit. And to me, one collarette is too many. I mean, your diagnosis of and don't get hung up on the term blepharitis. Because if you see collarettes, then they have Demodex, and that in turn is inducing inflammation, hence the term blepharitis.
It's so important just to look, and I think your point of turning up the magnification, great point.
Yeah.
Because you may look at it, if you have the patient look straight ahead, you're going to miss it. You will miss it probably 95% of the time.
So I love the fact that we're being told we need to speed up a little bit, and we're just stalling on this slide. But this is a patient of mine, Doug. This was somebody who came in, he's young, okay? This guy's in his early 20s, and you see me pulling on his lower lid, I'm shaking all over the place, but if you look at the base, you see all the debris, especially more temporal. You also see the neovascularization. This guy had the worst meibomian gland dysfunction. I wasn't even managing the DB. He was coming in for a clinical study that I was doing on MGD. Do you also notice something else in his lid? Doug, what do you see?
Yeah, that red line across there.
Yeah, you got the red line,
such a
Henderson line, but you also see he looks like he had a hordeolum. This kid, honestly, early 20s. This is not a disease where you wait for people to get older. You got to start looking at them. So, yeah, I mean,
there's that hordeolum.
Yeah, he was.
But look at those margins.
But also look at the pores and he needs some manscaping. Am I right, people? Somebody needs to,
And on we go. So the diagnostic tools we have available, we have tear osmolarity, we have MMP9s, we have meibography, we have, of course, the slit lamp, which is going to be the most important tool that everybody has. And if you don't have vital dyes, you should have vital dyes to use with the slit lamp. And then I think everything starts with a questionnaire.
in one way, shape, or form.
Well, yeah, if you have a questionnaire, whether your technicians are asking it, you're asking it, or you're having them fill this out, that's when that patient will disclose to you that they have a problem.
100%. Totally agree with you.
Do you use a questionnaire in your
I
practice?
do, I do. But I don't use a formulated one like the Speed. I know you love the Speed, and Speed loves you too. But I ask standardized questions of every single patient. And I think, if you find what works for you in your practice, just make sure you're consistent and do it on every single patient.
Yeah, yeah. And I think that that's what, even when they're return patients, because quite often when you're treating an ocular surface disease patient, they will see small gains and they'll say, well, I really don't notice much difference. But when they answer a Speed and it was 16 and now it's down to 6, then you can really point that out to them.
And you also use this questionnaire as a way to generate doing more testing.
Yes.
So a 6 and above, is that your?
Yep, 6 and above, and then that'll be the standing orders to go ahead and do osmolarity and inflammation. And then meibography, as I mentioned, we do on every patient as well. And osmolarity, and this has become so easy in terms of TruCara, which is the only device available to measure osmolarity. You can do both eyes, and technicians that are good can really capture both eyes in probably somewhere around 45 seconds.
Yeah. The nice thing about this is that you really can, you can describe it to a patient in terms they understand. And you've probably heard me say before, Doug, but it's kind of like when you look at your pee. Right? If it's that bright orange, you're like, oh, damn, I need to drink some more. Well, that is a high osmolarity. Or sometimes you look and your pee is super white, you're like, I'm drinking too much. I mean, and so I will oftentimes tell patients, your tears look like brown pee.
And we digress.
Yes.
What's interesting is and this, while it was one of the critics, people would criticize on osmolarity, is one of the hallmarks, and that's variability. I mean, it would just be like IOP. If we get IOP varying from eye to eye, I mean, that certainly is something that we need to take a close look at. Osmolarity is the same way. And I think that's an important aspect is you cannot get a false positive. If it's high, it's high. But because of reflex tearing, you can get a false negative.
Right.
And that's why you need to measure both eyes.
Which is why, I wish, I really do, that osmolarity was accessible as like IOP, or as accessible as we start thinking with, topography. Bausch & Lomb now owns TruCara, so I'm hoping they can make it a lot more accessible.
More mainstream.
Yeah, make it more accessible. Because for those of you that are like, oh, osmolarity, and we saw you, it is probably the best indicator of this disease state that is out there.
And if you get variability, that's another hallmark of it again, as I mentioned. Above 300 milliosmoles indicates that there's an abnormal osmolarity. So they've actually set that at about 308 when it gets above 308. But when you're seeing a difference of more than 8 milliosmoles, that's also an indicator. And we use that all the time. Patients love that metric. Yeah. And I think that's what I was really realized that with patients early, when there was no code and you'd have to charge them for that, and they'd ask when they came back, are we going to do that test again where we get that number?
Right.
Because after all, what's the first thing a glaucoma patient asks?
What's my pressure?
Yeah, what's my pressure? So evaporative dry, aqueous deficiency, if you have you can have an altered tear osmolarity with either of those. So you're not going to specify what that patient has, but it'll certainly, and this is the in-office osmolarity testing, again, can capture both eyes within about a minute. And it's reimbursable by most insurances. With your Medicare patients, it really is there's no prior authorization, there's good reimbursement on that. Each test card is somewhere around $10. But we do a lot of this testing.
Yeah, it's a great test, it really is.
And why? I mean, why do we care? Well, when we think about PEK, Mark, when we think about the breaking up of the cell membranes and the cell junctions, that's where that fluorescein pools. That's what we see is it's actually caused ocular surface damage. So that desiccative stress with that high osmolarity is causing damage on the surface. And we know if we can catch that early enough, but really by and large, most of the patients that come in, you're going to see that those cell membranes have already broken down, that you already have those tight junctions.
And it affects our patient's vision. I mean, you get, distortion in the vision, you get fluctuating vision, you get more light scatter, all the things that affect the quality of the vision.
And so if it's affecting the surface, then this study, which makes total sense, it would also affect the pre-surgical keratometry measurement.
Yeah.
So should we do as a precursor to surgery measuring osmolarity? Well, if it can detect when we can detect abnormalities with this, and 17% of the eyes in this study with high osmolarity had greater than a diopter difference in the keratometric cylinder values between the two surgical visits. So that's visit to visit greater than a diopter difference. That can be an impact on the IOL that gets selected for the patient. So
I think, don't undersell the importance of the preoperative exam in the optometric practice. Doug, I feel like we've been beating our heads against the wall ever since I think I even had hair on my head, that we as optometrists, we're the gatekeepers to this. And you should be doing everything you can to manage that surface. And, checking osmolarity, is fantastic, way to do it.
I agree. And again, something that's made this more recognizable to the surgical community, again, has been the high technology intraocular lenses and the light adjustable lenses and anything that we need a good surface for, and that you have to have as accurate as possible on the titration. Right. So
I think the bigger thing too, as we kind of go through a few more of these slides here, just talking about eyebrow osmolarity causing variance in K readings, is the fact that cataract surgery is refractive surgery. Patients' expectations are at a level they've never been before, as they should be. So even just small changes in osmolarity, as you can see here, can have effect on keratometry readings, which in fact changes the quality of that lens. And it matters. It matters to patients.
That's, if you disrupt the light on the surface before it actually gets diffracted in those lenses, then you're going to have that changes. And really, patients experiencing this are 7 times more likely to be that 20 unhappy. They see that, but they just don't see clearly.
Yeah,
and
I think that should say 20 unhappy, not 20/20 unhappy.
20/20 happy, 20/20 unhappy.
Well, or those 20/20 who are unhappy too.
Yeah.
Ugh, I hate those patients. Ugh. Do you ever have those patients, Doug, where they come in and you just go, oh my God, look who's on my schedule today? Yeah?
All the time.
Yeah.
So mybography in the office. Do you use mybography in the office?
Yeah, I do.
Yeah.
Yeah.
But you're on a case-by-case basis.
I do. I
Okay.
do. Yeah.
Okay.
But I use it honestly as a way of illustrating to patients, where we're at, where we should be, maybe ways we could manage it. I don't use it as treatment. I don't look at it and say, oh, let's rejuvenate your glands. But I do look at it as, let's try to slow down the progression of this.
I think it's a
atrophy.
motivator to patients when they see what normal is, and then you can show them that theirs is not normal.
It's all about modeling.
And there's a lot of difference. Even to the handheld device that you can capture that with the iLux. Almost everybody makes another mybographer, so it's really readily available, and that's why I think we're seeing so many more doctors get this. This is a little tool, this myverter, that really is helpful to flip the eyelids over on the upper eyelid.
And you can use it for the lower lid too.
Yeah, and it's not so much that we have problems, but our staff may have problems.
Well, speak for yourself, Doug, because I have a lot of problems. And I also have trouble inverting the upper lid. I've never been good at that. But that myverter, because it's weighted, it grabs a hold of it, it's fantastic.
And it has that little silicone tip, so it just holds on and flips over pretty easily. So yeah, handy little diagnostic tool. And what we're looking for is we're looking for atrophy. We're looking for the tortuosity in the meibomian glands, and we're also looking for the segmentation. So any of those things are going to be aberrant to normal.
Right. I think to your point though, Doug, it's really just kind of demonstrates to patients that you can show them, look right there. This is a Norwegian or a Swede, I could not tell by the paleness of the skin. But those glands look good to me. Those look really good,
He's not bad for a problematic patient.
No, yeah, there he is. Sven,
again,
is that Sven?
And with mybography, you can then do a diagnostic meibomian expression. You can target the glands you're looking for.
Yes.
And I saw that a lot of doctors said they use manual expression. Well, you can target the specific gland that you're looking for because you can see those areas of dropout. So
I think the future of this is pretty cool too. We keep talking about whether or not, where's AI going to matter, right? And I think, if you're concerned about artificial intelligence, not just writing your papers for you or, photoshopping you into a Peloton picture, in our practices, I don't foresee it taking the position of us. I think it makes us better. And you can look here that, there's going to be some deep learning, these neural networks, which basically create these algorithms that standardize the meibomian gland evaluation. I think sometime maybe we can do is like with diabetes, looking in the retina, and it can find other diseases associated with it, I think with the meibomian glands as well.
I think that both in meibography and other aspects that we're looking at is going to be important. And we're going to answer the questions that have come in, but we're going to move on right now to managing eyelid margin health. So, rate your level of confidence in your knowledge of current treatment protocols for Demodex blepharitis. So, all we're talking about is a knowledge of current treatments for treating Demodex blepharitis. Yeah. Very confident, somewhat confident, not very confident, or not confident at all.
About 60%, give or take, or somewhat to very confident. Respect, people, respect.
It's good.
They probably have come to some of our other programs.
I would guess.
And this is just like, a bonus.
What was the Demodex we interviewed last time?
Yes, what was
Felix?
that?
Or?
Yeah. I don't know. Felix.
Oh, that's right.
Yeah.
So treatment for Demodex has really become much easier than it was before, and I think the identification was one aspect, but even when you did identify and you saw those patients, there were no FDA-approved treatments. So want to talk a little bit about lotilaner?
Yeah, lotilaner, little shout out to our girl, LP, right? You know who we're talking about. Lotilaner ophthalmic solution, 0.25%. This came from veterinary medicine. And I think it was like scabies, Demodex is like on certain pets. I am not a pet person, so I can't really speak to that. But what I can tell you is that for those of you that have pets, this is something you've been using for a long time. And more importantly, what it does is it gets into the neural network of the mite, and for all intent and purposes, paralyzes them and kills them.
Yeah.
And so what you're doing is you're getting to the root cause of the disease. And everything else I feel we do, with the exception, we do have, IPL, which works on the exoskeleton, the tea tree oil and high concentrations might also maybe limit them a little bit. But lotilaner is the only treatment medication out there that when you put it in, it's a 6-week course because they run about 21 days, give or take, is the lifespan. So then the eggs hatch and you're like, nope, you got to go too. So I always liken it to this, that lotilaner basically is like when you see like mouse droppings, right? So the collarettes are like mouse droppings. And instead of just what we used to do is just clean off the mouse droppings, right? Now we actually kill the mice.
Going after the mice.
And if you look at their data, Doug,
Do you use that analogy?
I do all the time.
With
Are you
patients?
kidding? You know what? I tell them.
Mouse droppings on your eye?
Yeah, I do. Well, I have had to change a few things because the origin story of Demodex, and I think it's important, is that they are everywhere. Okay, they're in dust. They're on your cheeks, your chest, and honestly, from the minute you first were held skin to skin by one of your parents, and I think I used the term suckling to a patient once, and he did not like that. And he called to complain that I was commenting about suckling, but then I also said to him that you have an overproduction of the debris left behind, like it's basically, carcass, feces, it's just, and then he did not like that either. This was a dentist. It's like, come on, man.
Tough to please that guy who works in the mouth all day long.
Yeah, it's like defecating on my lashes. Yeah, that's what's happening. In their study, Doug, their Saturn 1 and Saturn 2 study, what they were looking for is complete eradication. So a collarette reduction of only seeing 1 or 2 on the 150 lashes. And I challenge you in your practices tomorrow to find that. The average person that was in the study had over 100 lashes. So when you look here,
that's an amazing number.
It's crazy because if you look, 50% of these patients compared to the vehicle had almost complete eradication. But if you step back a little bit and you say, what if it's less than 10? So you went from that 100 to less than 10, it's 85%. And then one other thing they were looking for is redness. They found that 25% compared to the vehicle, 8%. Because of the multi-etiological aspect of erythema, I find that really impressive that they were able to just reduce it at all.
That fast.
Yeah, I mean,
because I find also with treatment with time is also that erythema tends to get better as
Yes.
well once you've taken away those. So
what
it's not
this
an immediate response.
what
like
this
reduction.
study should tell you is that you have a treatment that will basically remove the Demodex mite. It's not going to remove them from your body. It's going to come back. It's like tartar on your teeth. But the truth is that we should be managing this yearly to kind of eradicate that. You with me on that?
I totally agree. I think we have to watch that, and patients will want to know how often does that, does it reoccur? Is it going to reoccur? And it really is just a change in the physiological environment of the eyelids that lets them overgrow. So
Totally. You know what? You're destined for that. What's our next audience poll, Doug?
what percentage of your patients do you believe have both Demodex blepharitis and meibomian gland dysfunction? 0 to 10, 11 to 25, 26 to 50, or more than 50?
I like the fact that our attendees here, that most of you, I spoke too soon. Somebody said 0 to 10. I was about to say that almost all of you, and then there's that one, I know it's that same person. It's got to be like, just a collection of 100 of you guys out there going, yeah, don't think so. Yeah. Oh, everybody thinks it's more than 50? I'm going to go 0 to 10. Mm-hmm.
Well, but as you digressed, you were talking about how it's good that we're actually seeing that correlation between MGD and Demodex blepharitis.
Yeah, 100%. So, yeah.
So with that, let's talk about Ursa and Rhea's study.
So interesting enough, Doug, if you'll allow me to take the reins here, I appreciate it. Love you. We saw Saturn 1, Saturn 2 were the clinical trials that Tarsus used to get lotilaner approved by the FDA. But they said, let's do like a satellite study. Okay, so this is Ursa and Rhea, and these are both moons that rotate around what planet, Doug?
I don't know.
You think it's Saturn, it's not, it's Jupiter. So anyways, who are these men, right? Who are these people? But what they did in this study was they said, you know what? There is a correlation between meibomian gland dysfunction, as we saw earlier in the Titan study. And so what they did is they picked patients that had meibomian gland yield secretion scores that were lower than they should be, but not completely zero. They took patients that also had Demodex blepharitis, and they did a series of patient-reported outcomes where they asked patients specific questions. So in the Ursa study, basically they kind of looked at the collarette grade, and they found that they were able to reduce the collarettes down to almost the exact same number they did with Saturn. So literally demonstrating here that they were able to treat the Demodex. But the other thing they did is they were also looking at, is there any improvement in the meibomian gland yield secretion scores? And you see the numbers on the right-hand side there. You see that there was a significant improvement in the meibomian gland yield secretion scores just by treating the Demodex. Hit that next slide, Doug.
And it's amazing when you look at these numbers and how that improves it. That's over a 50% increase in glands yielding secretions
Right.
of the patients that have Demodex and meibomian gland. So really, this has become the first time we've had a medical treatment that we can use with MGD when they have corresponding Demodex.
Yeah, to actually affect the meibomian glands. So when you start thinking about just managing Demodex, it's not just removing the glands, or excuse me, the mites themselves. The mites carry with them bacteria. There's a unique bacteria inside the mite called Bacillus olearum, which in turn can be affecting the meibomian glands. You know, we're seeing more inflammation, those little microabrasions. I don't get too fussed about, some nerd who's doing clinical trials, like myself, who is evaluating the meibomian gland yield secretion scores. I care more about patients. And these 3 patient-reported outcomes are, I think, the most impressive thing that came out of Ursa, is that they basically asked them before, to do the visual analog score, right? 0 to 100, 0 being my vision's never blurry, to 100 it blurry all the time or fluctuates all the time. So the lower the numbers, better, right? So about 50, the average 50 baseline for fluctuating vision reduced down to 20. Okay.
Those are incredible numbers when you're seeing 50% of the population to 20%.
Itching, as you already established before, that big sense, but look at redness too. To me, when a patient says to you, my eyes look less red, they're telling to you they feel their eyes are healthier.
Yep.
So, even if you're somebody who's a naysayer about managing Demodex blepharitis, I don't think you're realizing the sequelae that you're affecting on other disease states.
So let's look at an audience poll. Which of the following is your biggest clinical challenge when managing patients with thyroid eye disease?
While you guys are answering that, I want to take a couple seconds also to tell you that I think there's a direct correlation between hordeolums and Demodex. Just by virtue of the fact that we're talking about the meibomian glands and we're talking about this excess inflammation, also we start thinking about, what is the root cause of a hordeolum? Could it be an infection? If you have excess amounts of both inflammation and different unique types of bacteria, then I think we see more hordeolums. I personally, Doug, if I see somebody with a hordeolum, I start them on lotilaner.
I agree. I do the exact same thing, and I think there's a huge
I don't know if people can see us, but we are bumping this out. Boom, that just happened, people. Oh, let's get back to Ted.
Okay. Really, we have
Across
this pretty
the board,
well
man.
distributed around here, but doctors recognizing early signs and symptoms, coordinating care with other specialists, I think that's a challenge.
Yeah.
To find specialists in your area that may
100%,
administer the
totally.
infusion and do things or do orbital decompressions. Managing the ocular surface complications, yeah, absolutely, because they're tougher patients. They're not going to respond as much as some of your typical dry eye patients.
Yeah.
And deciding when to refer or advanced therapies, I think that's a gray area as well. So, treating really has been a watching and waiting type
Yeah.
of thing without the, and really we've used lubrication, used Prism for the diplopia that will ensue. In terms of lifestyle modifications, these are things that really have been used with dry patients in general. I think more looking at systemic thyroid disease control is probably a bigger area.
Yeah. I think it's always interesting that the number one risk factors for most of these systemic conditions is always smoking, but, kind of like, pull that cigarette out of my dead hand, right?
So really the medical treatments that we have, we now have the ability for the patient to have an infusion. But you have to find that specialist within your area to do that, and they show marked reduction in the proptosis with that.
Doug, can you go back to that slide? I'm getting a question from the audience. Can you name the drug that was up there?
Yeah, Tapizio.
Oh, sly. Yeah.
Surgical interventions, for years it's been orbital decompressions, which is a big deal. Yeah. That is a big surgery,
No,
or strabismus surgeries, eyelid reconstruction. So really these newer treatments that we have where we can use infusions are very important that we're looking at also.
Right.
Pharmacologic treatment using artificial tears, that's going to be an absolute necessity with these patients as well. And a lot of choices that we have with the demolents and the emolents are used in the different composition.
I think the important thing too is this question right here is how often do you recommend preservative-free lubricating drops, or even not even, I like the fact that we're asking preservative-free eye drops, because I do think that we're seeing that a lot more, but I'm curious to see what our audiences say.
There are almost 90% say always.
Yeah, and I think they're lying.
Yeah.
I think you're lying. Yeah, thank you.
You think they're lying?
Yeah, they're lying.
Well, I thought you said I think they're right, but no.
No.
Okay.
I wish they were right, but come on. When your patient's like, those are expensive.
So some of the preservatives that we have in there, they can be very, very toxic to the surface, and we've seen this over and over for the years, so it really makes sense. And I think where their patients are using that when they're making decisions on their own. I think when they go to their eye care providers, then they're being told to use preservative-free drops, or at least I would assume they are. But when they're making those decisions on their own and they're just going to the wall of tears in the pharmacy, I think.
The wall of tears. I love that. But just remember, BAK, it's a soap, people. You're basically breaking down. It's like a detergent that you're putting in your patient's eye. It's not necessary. It's just not necessary. Yeah.
Yeah, it does a lot of bad things to the.
Yeah.
And this is something that I think is so unique in this preservative-free filter, that it allows a multi-dose bottle and there's no preservative in it because it has that air valve in there, and it just everything flows one way.
Do we have a video, Doug, of like the phenomenal bottle that is used by TAEA. Is that here? Yeah. So watch, this is a hand model that we hired to do this. And what's nice about this is simple, easy, one drop comes out and then poof, that's it. So that air volume that you just talked about, that vacuum seal, if you will.
Notice the manicure on that hand.
It's amazing. Whoever that was, kudos to that hand. But you know, not all bottles are made the same. But if you're going to be using a multi-dose, then make sure it's a preservative-free bottle. Where's the camera? Right here. Yeah. Okay. Right there.
What is your first line treatment for MGD? Warm
Are you asking me?
No.
Okay, go ahead. You're asking
you.
the audience? Okay.
I'm asking the audience, but you can answer.
You know what? I wish we had all the above. I really, honestly, I mean, I don't know who wrote these questions and how we didn't really read them and edit them, and we just took it on faith. But yeah, really, IPL, first line treatment. Oh, I see. You've got a big nut you got to pay. I see you. You got that mortgage. Is that your first line treatment? No. Yeah. So.
And I think that's very typical that most individuals will go to warm compresses.
I don't do that anymore. I've really gotten away from, you know, and when I say warm, I mean it's like moist heat.
Yeah, moist heat.
You got to have a moist heat. If you're just telling patients.
Well, let's talk about that.
Let's talk about it. I mean, so that number on the right hand side there, okay, okay, it's 55% of patients are compliant. You know, compliant is a lot different than adherent, right? And to me, it's not that they don't want to do it; they just don't do it. So it's more of an adherence thing. And I think after a while, patients just lose sight of it. But I also, you know, we have to differentiate rosacea, because if you're putting heat on rosacea, it really doesn't help.
Yeah, it's going to get worse.
I do them in, just honestly, for me, the moist heat masks are a way of saying, look, you know what, we're doing some treatment, giving them some skin in the game to think about doing something. But I feel most patients just don't do it right anyway. I want to do it in office. I think an in-office treatment is the absolute best way to manage these patients.
I agree. And really using the way I use the out-of-office treatment is more of a maintenance. Mm-hmm. And then if they don't do that, they're going to need another in-office.
Right. It's like, are you doing the moist heat mask? What? Help me to help you. Okay? That's what I tell them.
So what's going on with the MGD pipeline? I think this is pretty exciting.
Yeah, it's exciting. I mean, Azura is coming out with something to kind of break down the keratin, but you know what? We'll wait until we hear more from them. So move on.
Oh, you know what? We have one of our correspondents coming up.
Yeah. So it's exciting. Most people are sick of seeing Doug and my face. We decided we were going to bring in some outside correspondents. And you notice something, Doug? They're all much younger than us.
Yes, they are.
Much younger. So let's bring in Dr. Cory Lappin. He's going to talk a little bit about pharmaceutical treatment options for MGD.
Again, I'm Dr. Cory Lappin, and I practice at the Dry Eye Center of Ohio. So all I do is see dry eye and ocular surface disease patients. And this topic of this case fits right into that. It's one we're all familiar with, and it's MGD. So the interesting thing about MGD is, like dry eye itself, it is a multifactorial condition. And just like with dry eye, we have to make sure that we address all the potential contributing factors to dry eye overall. We need to approach treating MGD a similar way, because it can have many contributing factors. And if we don't address all of those factors, then the patients can still be struggling with this. For instance, they might be basically suffering from MGD that's due to ocular rosacea. It might have contributions coming from Demodex blepharitis, or maybe they took Accutane, so they lost some of their gland structure due to the use of medications. So all these things are things that you need to really kind of dive into when you're looking at a patient who has MGD. All right. So here's the case that we had here. So pretty typical dry eye patient that you'd see. So a 64-year-old white male, and ocular history, dry eye, like many of us would see, would come in with MGD, over-the-counter artificial tear use previously, pseudophakic, so he's had cataract surgery. Systemic health overall pretty good, has some hypertension, but well controlled. Complaints were just general dry redness, some irritation, grittiness, what we often hear about, and then also fluctuating vision. That's a big one for us when we're thinking about MGD, because when you think about it, MGD is going to be related to issues with secreting the lipid layer of the tear film. And that lipid layer is what gives us that smooth optical surface, which helps give us clear vision, but also prevents the tear film from evaporating too quickly. So if you have disruption there, you're basically going to find that the vision is not as clear. And then when you blink, it's going to clear up or change. So anytime a patient talks about fluctuating vision that changes when you're blinking, you're oftentimes thinking about MGD. So when we took a look at the slit lamp exam, here's what we saw. So the first thing is I always look at the lids themselves. And you can kind of see in this picture here, he did have these telangiectatic vessels. They were kind of mild on the lid margin. So this is consistent with ocular rosacea. So he did have some mild ocular rosacea. Now, it's not just what you do see, but what you also did not see. And I did not see any collarettes, so that kind of waxy buildup at the base of the lashes that I would see with something like Demodex blepharitis. So I wasn't really seeing signs of that. But when I looked at the meibomian glands, you can see here, it was kind of that thickened toothpaste-like appearance. They were capped, so when you press on the lids, you want to see an olive oil-like secretion. But for him, it was much thicker, so I know that the meibum quality isn't where I would want it to be. So it has pretty significant MGD here. No corneal staining, though. Now, I also took a look with meibography. So this is really kind of giving me a look at the anatomy of the meibomian glands and more detail here. So upper and lower lids here, and what you want to see with meibography is you want to see these glands kind of look bright white here. And you can see on the uppers, there are a lot of areas where it's kind of a hazy gray. So we call those ghost glands. So the structure's still there, but they're really kind of sick glands. They're not functioning like we'd like to see. And then when you look at the lowers, especially the lower right, you can see that there's significant gland dropout. So these meibomian glands have taken some hits, and ideally we want to keep what we have here. We want to preserve this structure. We don't want to lose any more of the glands than we've already lost. And then we looked at basically the functional aspect. So I always say that when we're looking at meibomian glands as structure, but let's see how the tears are actually functioning here. So tear breakup time. You can do this with fluorescein. I basically have an ocular surface analyzer, so I'm able to see this non-invasively, which is great. And remember, a normal tear breakup time is going to be about 10 seconds. And for my patient, he was at 4.4 seconds in the right eye and 3.06 seconds in the left eye. So significantly reduced tear breakup time. And this can be a sign that that lipid layer is not functioning the way it should. It's not preventing the tears from evaporating as much as we'd like to see. All right, so now I'm going to join back with Marc and Doug, and I'm going to discuss with them how I approached treating this patient.
Thank you, Cory.
Wow. Pretty cool. We got a polling question before we bring Cory in to discuss his treatments.
Okay,
huh?
okay. Let's.
Yeah.
Based on what was presented in the case, which of the following might you recommend? Cyclosporin 0.05%, lifitegrast 0.5%, cyclosporin 0.09, cyclosporin, I think that should be 0.1, topical steroids, perfluorohexyl octane, or none of the above.
I love the none of the above. I need to know what you're thinking based on Cory's case. And Cory's here. We got Cory. Okay, you say it to his face. Cory, they need to say it to your face. None of the above. They're not going to treat this person at all. Cory.
Yeah, that's called the ostrich treatment. Your head goes in the sand, and you're not responsible for anything then.
Okay, so Cory, these are our viewers, and so, you know, it's the comments by Dr. Cory Lappin are Cory Lappin's only. We are not calling you ostriches. We're excited for you guys. So awesome. Yeah, moving on.
Cory, great case.
Yeah.
Oh yeah.
So what are your treatment considerations?
It's also it's what we see all the time, right? That's my big thing. Like I wanted to pick one. That's something we're going to see every single day. And we always talk about dry eye being multifactorial, but really it's the fact that MGD is multifactorial. So for this, I mean, I would be interested in kind of think what you guys do. If you see MGD and you see rosacea, which one do you think of treating first? Which one kind of do you the chicken versus the egg situation in this one?
So we were just talking before your case came up, and this is where I have a hard time with like recommending moist heat masks. You know, putting more heat on that rosacea, you know, inducing more inflammation. I think I would probably go with both. I mean, I want to try to bring down the inflammation and try to get those glands expressing a little bit better. I don't know. I'm going to do both. Yeah. What are you going to do?
Yeah,
Or
yeah. What you just said, though, the first thing for this I would want to point out is that I'm really big on foundational therapy. So, like, I like omega-3 supplementation. I know some people aren't big on that, but I've found that's been really successful when you get the right ratios. Not all fish oil is created equal. So if you get the right one, I found that successful. But the one thing I would not do in this case, and you nailed it, Mark, is I would steer clear of warm compresses.
Corey, could you repeat that?
Would not touch.
Could you repeat what you just said 2 seconds ago? Mark, you did what? What did I do?
Because that's not going to get repeated again. Go ahead, Corey.
Yeah, it was how you said, Mark, you would avoid using warm compresses. That's key for this, because heat is going to dilate those abnormal telangiectatic vessels and make it worse. What they've actually started doing is having them use cold compresses. They actually find that those are really comfortable. It's not going to actually fix the problem, but it's actually very, very comforting for that. And for this, you're going to want to actually try to address the root cause of this. So for this particular patient, I put them on, the foundational treatments of omega-3 supplementation. Then I also put them on some form of lid hygiene. But then the other thing I also did is I did a series of IPL, and I added MIBO, perfluorohexyloctane. Because the thought process here is that with MIBO, I can very quickly help with symptoms, but that's going to help that evaporative element that we're going to see from the MGD. So from a pharmaceutical perspective, it's going to, you basically, like you can see there on the slide, it's going to inhibit that evaporation. But the biggest thing is now is the patient's going to feel that difference within 5 minutes. And I know you were discussing earlier, you want to focus on how the patient feels, right? It's great that we can do all this data and we can show this, but at the end of the day, it's how the patient feels. So giving them something that can help them feel better within minutes is great here. So to me, that's something that's going to be quick acting. And then the IPL is going to try to be addressing that root cause. So with IPL, if I do 4 treatments with this, it's going to address several different things. So one thing is it's going to help shrink down those pro-inflammatory telangiectatic vessels that are causing the inflammation that can be contributing to the MGD that we see so commonly in ocular rosacea. We also know that it's going to basically kickstart the glands, so they're going to have better structure and function. It can potentially bring down the microbial burden. Now, in this case, the one thing I think that's really important is what I did not see, is that I did not see collarettes, because if I would have seen collarettes, I would have been hitting them with lotilaner, because I got to get rid of the Demodex in the case of basically MGD, or if I see ocular rosacea. But this is really good at helping with any of that that's basically on the face as well. So to me, it's really nice to do IPL because it's an in-office treatment. It's going to address several of the contributory factors to a case like this. So that's why I really, really like this for my MGD patients, especially if they have ocular rosacea.
Love it.
Corey, I really like your approach in that you take care of the acute nature of the symptoms in the patient by giving something they're going to notice, and then you do a couple of longer term, using both the IPL, which is going to be, some pretty quick relief, but is going to be long-term repair of damage that was been done, and then using the nutraceutical also as a long-term therapy as well. That's going to take a little bit longer, but it really makes a lot of sense to have that. Take care of the acute nature, then take care of the damage that's been done.
I think the other thing too is that you're doing a lot of these things in office. The expectation is that, we want patients to manage these at home, but we know that patients are just not adherent. They just don't do what we need them to do. So any sort of interventional treatment you can do in your office is only going to benefit your patients. And, you really honed in on that.
Yeah, that's probably been the biggest shift we're starting to see with dry eye treatment. And oftentimes I still do say that, many of us say that this is an or, not and. A lot of times they will be having a prescription and doing office treatments. It takes a lot of things to manage a multifactorial condition. But like you said, the less that we put that burden on them to do at home, the more successful we are with this. Now, the other thing I would say for this patient, let's say I still found they had a lot of inflammation. This is not like one and done. This would be great if this works alone, but then there's also coming into where I think of that poll where they talked about cyclosporin, they talked about lefidograst. Those are all still very viable long-term solutions if this patient would still have a lot of inflammation, which we often see with rosacea. But the thing I like to show here is this patient responded beautifully to treatment. You can see here the non-invasive breakup time was, it was basically in the tank before, and now you can see right there, you don't even have to look at the numbers, but just look at that map of that non-invasive tear breakup time. You can see you had all the oranges, the reds, the yellows before. and it's completely green afterwards.
That's
So
amazing.
that really is just showing you how well patients can respond to this. And the big thing with this is just remember, if there's different things you see, try to treat each one. I could have only went for the MGD and kind of left the ocularization alone, and I might have got a little bit of improvement, but I think I would have been chasing my tail. I would have just kept coming back. So really kind of finding something that addresses everything. And I love, Doug, the way you put that. Really, finding something that can help acutely, but also long-term, because patients, they always want a relief and they want it right away. So if you can kind of work on both that long-term sustained relief, but still giving them something that's going to help right away, that's what patients are looking for.
Beautiful.
Beautiful. Cory Lappin,
for
live
joining
from
us, Cory.
Cincinnati, Ohio. We appreciate your contribution to the Eye Report.
Yeah.
Absolutely. Thanks, guys.
Thanks, Cory. Wow. Cory,
Great
nailed
case.
it. Yeah, it was a really good case because it was simple and yet complex at the same time.
Yeah. And what it did for the practice is it also generated revenue along with helping a patient.
Well, that is a beautiful thing, my friend. So let's, rate your level of confidence and your ability to apply new treatment options for your patients with the MGD, the MGD. The MGD.
Very confident, somewhat confident, not very confident, not confident at all. We're seeing a somewhat confident in here and very confident. I think the doctors that have technology that they are going to implement within the office tend to be those that are going to be a little bit more confident because they've actually employed those devices to help the patient.
Yeah, definitely.
So let's talk about some of the MGD treatments. We have thermal pulsation, as Cory brought up. We have IPL treatment, and we have manual gland expression. So I know that you utilize a lot of this technology within your practice, as I do.
Yep, 100%. Love that manual. I like the manual gland. I love doing that kind of intelligent heat, manual expression. More importantly, mainly because I have control. Like you said before, Doug, you look at the mybography, find the glands that are atrophied, spend more attention on the ones that aren't.
Yep, and that can be really targeted at that particular point, where
Right.
in general automated vector thermal pulsation, I really evaluate on how the MyBIM is coming out, how difficult it is. If it's overall that it's thickened and I can get it, then I'll do with an automatic vector. Otherwise, I'll use the intelligent heat and manual expression on the
Yeah, you
patients.
see the application. Oh, we didn't get to see the application. It's fine. Move on. Moisture chambers, lid hygiene. These are things that obviously we can have patients do at home, for that home treatment. I do think that managing, the bacterial load on the outside of the eye using, something that kind of like has a surfactant, a cleanser or something, even hypochlorous acid, I think definitely works for patients.
Well, in hypochlorous acid, if we talk for that for a moment, makes a lot of sense because one of the ways that I believe that we get Demodex proliferating is because they have food. And the food is a biofilm, which is a polysaccharide, which is made up of bacteria. And if we can perhaps reduce that bacterial load a little bit, we might be a little more, take away one of the elements that causes combustion, which is, take away the food source, take away the fuel.
Yeah, so I mean, that really goes to the heart of if you're still managing Demodex, still managing MGD, it's like having patients have a little skin in the game, having them do something to kind of actively clean the lids.
And that way they also take some responsibility for their own care.
Yeah.
And I think that's important too. They have to own the disease entity.
Yeah, definitely. I'm right there with you, bro. Okay. Now, I'm not doing a lot of probing.
Nope.
I drink way too much coffee, so can't do it. The little mask and probes, but that is available to get in there. Are you just still doing the semi-automated thermal pulsation? Kind of like the Eyelid?
Not as much as they used to.
Yeah.
And really because I already have a mybographer, so I don't use the video on it.
Yeah.
But it's a great patient education tool.
I mean, what's nice about that is that you just go from room to room,
Yeah. Yeah.
So.
Some of the other okra treatments, doing BluffX. I still am big fan of BluffX. Taking away that biofilm because biofilm really, you mentioned about keratin in those glands. It's actually esterified biofilm that occurs in that. And while there may be keratin cells in there, so breaking that up, and some of the studies that you mentioned Azura did, saw that it took 200 degrees Celsius to melt that. Well,
Yeah.
the eyelid's not going to handle that. So cleaning the eyelids, looking at some of the treatments, I think are also very important. And then the automated vector, which was the LipiFlow, we've seen that going through that, some of the other mechanical treatments. And I think Lindsay's going to touch on this as well, the low-level light therapy treatment. So we'll save that for...
we'll let Dr. Bull talk about that.
for her, yeah.
us.
We'll
This
let her.
is interesting, you know? Just,
radio
you know,
frequency?
Yeah, radio frequency, and I think that's probably something that Dr. Bull uses in her practice as well. Look at those eyebrows. Wow. That is amazing. Do you see that?
Speaking
Were
of
those
doc-
hers? Yeah.
I don't know.
Yeah.
Speaking of Dr. Lindsay Bull, here she is. And why don't we go through her case?
Well, why don't we let her go through her case? Pretty excited that she's joined us today. You know, we could go through it, but let's let her go through it. So.
Yeah, we'll let her.
Hi, everybody. My name is Lindsay Bull, and today we're going to talk about a case study that I had over a female patient with meibomian gland dysfunction, which is a really, really key diagnosis when we're looking at the entire dry eye spectrum. And we're going to talk about what options we gave her as far as what treatment protocols we wanted to provide for her and how we thought that she would best respond to the different options that we provided as well. And so if we get right into her case, what we saw was back in December 2023, the 63-year-old female presented to our office as a referral. So she had already been being treated previously by different providers, and she had currently used lodiprednol, so she was on a steroid on the tapering schedule. By the time we saw her as a patient, she was down to just 1 time a day. She reported that she was using lipid-based artificial tears over 8 times a day and also gel or ointment before bedtime, and still was having quite significant symptoms. If you look at her symptom list, she complained of dryness, redness, irritation, burning eyes, fatigue, occasional foreign body sensation. So really the plethora, all encompassing of the dry eye symptoms when we look at what our patients typically are going to complain about when they come into the office. For all of our patients coming in for a dry eye evaluation, we are doing a dry eye questionnaire. Typically, we're using the SPEED questionnaire, which you can see there on the right side of the screen. And she scored in the severe category. So her symptoms were fairly significant. She was really, really bothered, and she felt like everything that she had been doing really wasn't working. She really wasn't getting a lot of relief. So when we took a look at her behind the exam or behind the slit lamp, we found that her vision was 20/25 in both eyes. Her pressure with eye care was 15 in both eyes as well. We did notice some telangiectasia with turbid expression from her glands upon pretty firm pressure under the microscope. One of the things that we always have our patients do is look down. We want to evaluate for Demodex and on their upper lids. And so we had her look down. Both eyelids were free of collarettes. Her cornea did have some mild SPK noted, mostly inferiorly. And if you look at categorizing of your dry eye, when somebody's coming in with a mild SPK, that's already somebody who we can say is well established, at least moderate dry eye. And so any form of SPK on that cornea is really going to take that patient out of the mild dry eye category, put them in that moderate staging. Her conjunctiva also had some marked staining noticed, and her tear breakup time was fairly low in both eyes, about 5 in the right eye and 4 in the left eye. So at this point we said, okay, we need some meibography. We need to see what these glands are looking like so we can get a better evaluation. This is what we give all of our patients when they're coming into the exam room after we've done their meibography. And so we give them this image to hold in their hand, and we say, this is what it looks like if your glands are normal. This is what it looks like when we're starting to see mild to moderate meibomian gland dysfunction. And then this bottom picture is what we see when we get somebody who has severe meibomian gland dysfunction. We can see quite a bit of gland loss, gland atrophy, truncation. The glands really, you can see, become quite hardened. We're not going to get great oil expression out of those glands. And so we always show them this image, and then we show them their glands afterwards so they can help to categorize themselves. Because I think a lot of patient diagnosing and patient treatment is having the patient see what their images look like so they believe what's going on, and they will buy into the treatment processes or treatment options that you're giving them because they don't want to get to that severe category. So the patient was holding this in her hand when we pulled up her images. And this was her meibography from 2023. On that right eye and left eye as well, you can see that she has quite a bit of truncation. She has quite a bit of atrophy, a little bit more significant on that left eye than that right eye, which also plays hand in hand with that decreased T-but from in her left eye versus her right eye as well. So we were dealing with moderate to severe meibomian gland dysfunction or meibomian gland loss in both of her eyes. And so at this point, we diagnosed her with dry eye secondary to MGD. We also diagnosed her with ocular rosacea due to that telangiectasia that we were noticing on the lids. And we started going over our plethora of treatment options. And that's one of the things that we've really started to become lucky with in the dry eye categories. We have so many options now and so many ways that we can try to treat these patients. And so we said we can continue with the warm compresses, although there are some theories that potentially you don't want to do that warm compress on patients with ocular rosacea. Obviously, we wanted to continue some kind of lipid artificial tear, preferably preservative free. We were definitely going to recommend some lid hygiene to help with bacteria overgrowth on those lids. And then we wanted to consider starting perfluoral hexaloctane, QID, potentially even starting an immunomodulator, like a cyclosporin, maybe even some oral doxycycline or topical azithromycin. And then in in-office procedures, one of the things that we offer at our office is IPL with LLLT. And so that's one of the things that we typically will offer our patients, especially when we start to see meibomian gland loss, that we would diagnose or we would categorize as moderate to severe. And so at this time, the patient really said that cost for IPL was a pretty significant factor in her decision not to proceed with that. And so she did want to start with that perfluoral hexaloctane QID, and in addition to her current protocol that she was on due to that cost of that procedure. And so in March 2025, so about a year and a half after that initial evaluation, the patient returns for a repeat dry eye evaluation. And her continued complaints are that soreness, that irritation, that burning, and that fatigue. She was using the drops that were previously prescribed about 3 to 4 times a day, was on those artificial tears, using that ointment at bedtime as well. And her exam findings were very, very similar to what we saw a year and a half prior. So her visual acuity still 20/25, IOP is 15. We still were noticing that telangiectasia with that turbid expression, still no collarettes present. Still some mild SPK noted, mostly inferiorly. That conjunctiva had that marked staining. Her T-but had decreased slightly from that exam, not significantly, but a couple of seconds decreased in both eyes. So if we look at our meibography from a year and a half later, what we notice is additional gland truncation, additional gland atrophy, not significantly changed from her previous exam, but we were definitely seeing some progression of the disease state that we wanted to treat a bit more aggressively. One of the tests that we also do when they're on are behind our equipment is we look at their blink rate. How often are they blinking, and what does the quality of that blink look like? And what we found with her right eye was about 80% of her blinks were incomplete, but with her left eye, 100% of her blinks were incomplete. And so when you think about how important that is, and the purpose of that is we really want that upper eyelid to meet that lower eyelid, to press on it so that oil can be secreted. When we're not having those complete blinks, we're not getting a lot of that meibum secretion that can really contribute to furthering of the meibomian gland disease and really contribute to that lack of meibum being within our natural tear film. And so this is something that we definitely wanted to address with her as well. And so at this point, I'm going to turn it over to the guys. We're going to bring them in for this conversation, and so that we can discuss this case and talk about some learning points with it as well.
Wow, thanks, Lindsay. We can't wait to talk to you about it. Thanks for bringing us in. Thought we were bringing you in. Who's in control of this show?
Obviously, we lost it.
Yeah, it's when our correspondents become leads. But okay, whatever. So we have a first question. What is it, Doug?
Based on what was presented in the case, which of the following might you recommend?
Ooh, let's see here. Lid scrubs, cleansing wipes. Thank you, everybody. Thermal pulsation, IPL, manual expression, warm carbon, LLLT in the HIZA. Mm-hmm. You notice nobody picked warm compresses.
Nope. I think you've frightened everybody.
I know.
I think you've frightened. Lindsay, great case.
Wow.
Thank you so much.
Thank you.
Okay, I think everybody needs to know Lindsay is a trooper. Girlfriend just flew in from Chicago to present her case, and you don't even look exhausted. You look amazing.
We were supposed to get in at 8 p.m. last night, and when my plane rolled in at 5 a.m. this morning and everybody was arriving to the airport for today's flights, I realized that we're just going to have to power on vibes and good effort today.
Well, an amazing case also.
Yeah, you're doing it.
Well, thank you so much.
Yeah, I really like the way that you incorporated the long-term management into this. I think it's so important. And how you found other areas of inflammation that were going on, like looking for the Demodex, looking for the collarettes, treating what was necessary. So really, the long-term management. I think this was a great case.
Yeah, I completely agree. So
Thank you
So
so
now
much.
what?
So,
So now,
with this patient case, one of the things that we commonly look at or have commonly looked at really since lotilaner was came about is I don't think that any of us were having our patients look down enough. And so that's one of the things that I have incorporated into all of my dry eye patient exams, but really all of my examinations, because you would be shocked at how many patients you are missing Demodex on if you're not having that patient look down, how many collarettes. Now, I was really lucky in this case. I did not see a whole lot of collarette activity with her, since she did not have a whole lot of Demodex activity. But what we did find was that ocular rosacea and then that incomplete lid closure when she was blinking. And I don't know about you all, but a lot of my patients, when I find that they have incomplete blinks, what that ultimately leads to is at nighttime while they're sleeping, their lids are probably not having that nice complete seal as well.
yeah.
And so that leads to a reduction of the meibomian gland expression over time. It can lead to a lot of gland dropout, gland atrophy. And so that really was going to be my focus with her, is that how can we make the glands that she has, how can we make them look better?
Yeah.
I think the one thing that patients commonly want to see, and we have anterior seg videography on our slit lamps. And so I will bring them back after I do these IPL sessions on them, and I will video them and I will show them what their meibum looks like from the first session to the last session. I actually had a patient last week. She was a younger female. She started bringing her family members in so that they could see the video and they could watch that meibum come out, because I think you all had mentioned it before, but seeing is kind of believing for a patient. So if we can show them that this is what you started at and now the therapies have worked and this is what you're ending at, they buy into their condition. They're going to continue with their eyelid hygiene a little bit better at home. They're going to end up with that continued case management at home as well. So for this patient, we elected to do 3 sessions of IPL with the LLLT. What we have found is that pairing those two things together can be really impactful for patients, because we can really ablate that ocular rosacea with the IPL, but then we get a lot of that neural recovery and that regeneration of healthy tissue with that LLLT. Helps to keep that meibum really nice and liquefied too, so that when I go in afterwards and express, it comes out a little bit easier. And so we typically space our sessions about every 2 weeks. And then I did assign this patient some blink exercises as well, because we know that poor blinking patterns, like I mentioned before, is going to cause an increase in meibomian gland dysfunction too. So I think one of the important things that we really need to look at when we're recommending IPL for anybody is who is and who isn't a candidate. And the first thing I always look at is what is my patient's skin tone. So you're looking at that Fitzpatrick scale. Types 5 and type 6 are not going to be candidates. So what we will offer those patients in a lot of cases is maybe just doing the LLLT versus combining it with the IPL, so that we're still able to offer them some kind of therapy or management for that. We want to make sure that our patients are staying out of the sun for a couple of weeks prior to their treatment, but also throughout their entire treatment process as well. We know IPL targets that melanin, and so we want to make sure that we're not going to cause any risk of burning or pigmentation changes to the skin. And then you're wanting to look at patients who have active infections, history of keloids, or are on certain medications that are also going to make them a little bit photosensitive too, because those patients are not going to be candidates for doing IPL either.
I'm really, you mentioned an aspect on this that was so important, and that was looking for that inadequate lid seal and looking for that partial blinking, because that is just going to create more exposure for those patients, and they become very, very difficult to manage on that because of their underlying inadequate lid seal and partial blink.
Yeah. Do you use like your transilluminator?
I do. We do the Corby Blackie test on our patients in the office. So we'll just take a pen light. We have them gently close their eyes. And I always say, gently close your eyes as if you're sleeping, because you tell a patient to close their eyes and they're automatically going to squeeze them really tight, and it's going to look like their eyelids seal better than they do. So close very gently, and you're going to see if you have any of that glow come back at you through that lid seal. And if you have that light glowing back at you, you know that you have that inadequate seal, especially while they're sleeping at night.
So Lindsay, I know we're probably coming up on time, and I'm sure I'm going to get from our producers back there in the box that we need to hurry up. But no, this is important stuff. Can you demonstrate to anybody watching what your blink exercises look like? Because I oftentimes tell patients, you need to blink more. I just want you to stop, collaborate, listen. It's blink time. I just made that up just now. And I want them to look across the room, find some hottie, and just blink a few times. What's your What, describe the blink exercises.
So we will tell them to find something across the room, whether they're watching television, whether they're on their computer, whatever they're doing, to hold their eyes open for 3 seconds, to close gently for 3 seconds, and then to squeeze tight for 3 seconds. I tell them to do that 10 times, give it a minute or two, do it another 10 times, give it a minute or two, do it another 10 times. And I want them to do 3 sets of 10, 3 times a day. And so the goal would be is to strengthen the muscles, the orbicularis oculi, to help with that natural meibum secretion there. But frankly, even if it's not helping the muscles, we're really getting them multiple times a day just to focus on their blinking and to get some meibum secreted there.
Yeah, we talked before about just getting patients to have some skin in the game, just to be conscious of the fact that they should be managing this as little as it is. So, you know, when you're talking here about, you know, IPL and LLLT, helping MGD. How do you differentiate the two? When do you decide when to do one versus the other?
So a lot of times, you know, when we see a patient with a Fitzpatrick score of 4 or under, we're going to automatically just do both. We think, and studies have shown, that they work more effectively when combined together. So the patients that we're not doing the IPL on are going to be those patients with the skin types that are too high for it to be a safe procedure for them.
So when do you differentiate between which color light you're using?
So as far as the light, when you're looking at anti-inflammatory properties, you really want to use the red light. When you're looking at Demodex and an antimicrobial property, we're going to use the blue light. And I have even done both things on patients where they get the red and the blue mask, depending on what we're seeing under the microscope.
Aren't they selling those at cosmetic counters nowadays?
They are.
It's the red, right, that they're selling?
It depends on which company you go with. But yes, the red is the most common. I actually have one at home for myself for cosmetic reasons.
Yeah. So would you advocate that for patients? I mean,
you know, I don't think it's a bad idea. Now, I don't think we should just go on Amazon and buy just any one. I think we should be looking at reputable companies so that we're not, you know, damaging our skin at home.
Yeah, you're going to be like, so my wife is going to just find, it's Christian Dior. It's going to be amazing. It's amazeballs. It's going to go with my YSL bag and whatever else. So,
and she's probably right.
Okay, you can stop. You can stop right now. There you go.
Just in case he's listening.
She's not. I know that. So that's awesome. You know, the other thing that I loved about your case is the fact that you laid out what you're going to be doing. And I think oftentimes, you know, you need to let patients know that, you know what, if it doesn't, you know, if we don't get to where we want to be, then we have other options. The next time you come in, we're going to talk about doing something. And oftentimes you find patients just say, well, why do I have to wait? Why don't we just do it now?
Well, you're emphasizing the chronic nature of it, so the patient fully understands that this is something that is, I think you said earlier, Mark, it's not a one and done that you're going to require, and that's their physiology, that's their makeup.
Yeah.
Yeah, and in this patient's case, you know, we had talked about IPL a couple of years ago, and she decided for financial reasons that she didn't want to proceed. But then as her symptoms worsened and persisted, she changed her mind. So I think having that conversation early on is really key and really important, because then that is putting a trigger in the back of the patient's mind that maybe we need to do something at a later date if what I'm choosing today doesn't improve.
You know, you bring up a great point on that, and that's how many patients, if you introduce that there's therapies they could have, how many will come back a year and a half, 2 years later and say, now I'm ready.
Yeah,
exactly.
And, you know, it's been a cost versus benefit type of analysis that they've done, said, now my symptoms are bad enough, now I need to listen to what my doctor said.
How did this patient end up?
And you give people a little bit of time to put money in their flex savings accounts that way too. So we've had a lot of patients say, you know what, I don't want to do it now, but when my renewal for my insurance comes up, I know that this is what it's going to cost and I can set aside that money.
Yeah.
Yep. They can put it in their HSAs and they can do things like that as well. So it's.
So how'd they do? How'd this patient do?
Patient did really, really well. So she came back about 4 to 6 weeks later. And really her complaint was, well, when I'm outside and it's really windy, I still feel irritated. And that's the one thing as an eye doctor that I haven't figured out how to fix yet is the wind outside.
Oh, just
and
tell them don't go outside.
Don't go outside. Yeah. But her speed score had significantly improved. Her T-BUT was still a little bit low, but improved from where we had started. And so our hope was that as continued improvement, that we were going to see her feeling really nice. And what I will always tell patients is that we may do a maintenance round of this IPL, you know, 6 6, 12 months from now, where we're not going to do all 3 rounds or 4 rounds again, but we may just do 1 pulse round to kind of regenerate and get you feeling good again. And so she was open and aware of that. I should be seeing her again in about 6 months.
Did you see her at the 3-month mark or no?
I saw her at the 4 to 6 week
gotcha.
after we finished the final IPL.
Sweet. Yeah, great case.
Great case. And the whole idea that you're educating that patient also and saying, really, it's a marathon, not a sprint. We're not going to solve this overnight. There is no magic bullet, but we can work on this and we continue, because a lot of this is you're taking care of damage that's already been done as a result of the inflammation over the years.
That was a lot of idioms you just threw out there. I think those are idioms. I don't know. Lindsay, thank you so much for troopering in here. And
appreciate it.
Yeah. I mean,
it was a pleasure, and it was always a pleasure chatting with you guys.
And having our correspondent, Dr. Bull from Tulsa, Oklahoma. Thank you so much.
Thanks, y'all.
We're going to do question and answer at the end. We're going to hold all that because as the questions come in, a lot of them are going to be overlapping and some of them we're going to answer on the way. So we're going to...
I think it's also important to basically say that we're not going to be answering every one of them. So, well, I was just thinking, you know what, if you put a question out there, don't get all upset if we don't answer it, because we're being told that we're behind. So we need to move things a little faster.
Corneal nerve health and inflammation. Another question here, which of the following do you believe plays the most significant role in corneal nerve damage and inflammation? This is a really important one here.
Yeah, mechanical trauma from contact lens wear, chronic ocular surface neurotrophic factors, systemic conditions. You know what? Why do we not have all the above? Yeah. So which one do I think plays the most? I think it's B.
I'm going with B.
I'm going with B too. Don't be skewed, people. Okay, don't be skewed. You stick to what you guys want. But I'm going with B.
It's just more and more that we see the relationship with chronic inflammation, and then the neurotrophic component, which may not be a neurotrophic keratitis yet, but it's heading in that direction.
Yeah.
And I think that we see that complex system. I mean, with the afferent messages going from the corneal nerves going to the central nervous system and then returning to all of the tear producing organs. So it is a complicated, but we're seeing more and more, hearing more and more about different medications that will activate that afferent pathway to then in turn get the efferent message to the tear. And I think it's important that it's producing a full quality tear when you do that. And if you don't do that, you're not getting a full quality tear. If you're not getting that message from the corneal surface that goes to the central nervous system.
I think it's also important as you just think about, the types of sensations we have, Doug, and it's a perfect, lead in here. The nociceptive pain, those are the little nerve endings on the outside of the eye. They can interpret small, tiny changes in temperature, humidity, but there's also ones where extreme changes, like extreme cold or that capsation, which is like the heat that's in like chilies, right? When you start thinking of your Scoville heat unit, I love asking patients if they watch Hot Wings, right? Are you watching Hot Ones or Hot Wings? See, I don't even know what it's called. Somebody put it in there. I think it's Hot Ones. That type of thing.
See how hot they can go.
Yeah, seriously, and how much it makes their tears. But then you have neuropathic type pain as well as acute pain from that nociceptive pain, which we kind of almost would call COSP nowadays, I think. Chronic pain and itching. So, you have to kind of see that there's an extreme disconnect between what patients are feeling and what you're seeing. And I think when we start talking about corneal nerves, it's like, I think years ago we used to just kind of disassociate with these patients. There's something wrong with them, they're crazy. Now, I think what we really need to do is try to associate why they're getting the symptoms or signs that are just not correlated.
And is you really have to listen to the patient, and then also you look at that patient, and the neurotrophic is totally different than the neuropathic. Than we see that. Although they may come along in correlation with each other, but the neurotrophic is simply that patient looks horrible and they don't really feel much. Yeah. And that neuropathic is you don't see much, but boy, that patient is in extreme pain that's triggering those receptors.
Yeah.
And really the corneal response to contact lens use, Marc, when you look at this and you look at contact lenses over the years, I really don't believe it's a question of if, it's a question of when
Yeah.
you have that downregulation of the nerves. Because with all the advent of all the materials and all the solutions and everything we have in new contact lens technology with, edge angles and wetting angles and all of that and materials. Did I?
Yeah,
lose
you're
you
talking
on that?
Greek to me. I mean, contact lenses, yeah. I mean, but you're 100% right. I mean, this is a thin piece of plastic sitting on this vital organ that we just expect to just have no real long-term consequences when we all know they do. We do.
And I've said, this a number of times, that is, if we knew what we knew about the cornea now, we knew then,
Yeah.
and contact lenses didn't exist,
Right.
and then somebody came up with this idea of, hey, let's put a piece of plastic on this corneal tissue, it probably wouldn't fly.
No.
But we were all raised with it, with contact lenses. So
This is some good stuff in here, Doug. I don't know what it is, but thank you. Thank you, guys.
And really what we know is the hypoxia, the mechanical trauma, the adaptation that we see with the contact lenses. And so we're really looking and saying, where is that role and what does that cause in the inflammatory cascade?
Yeah, and I think we do, I mean, we're not hyper-focusing on the fact of context, but think about what we do professionally as optometrists. I mean, aside from the fact that we put our patients on drops, we talked about preservatives before. And I think the preservatives have a really significant impact on the sensation of the cornea. But, this inflammation, especially associated with contact lenses, is something I feel that we need to be cognizant about. Because, you look at here this innate and adaptive immunity, which basically builds up over time, especially as the eyes get more inflamed, and that perpetuation of this cycle becomes chronic. And at what point as clinicians are we going to intervene and be proactive so we can prevent long-term sequelae?
Because after all, the contact lens material did not change. The underlying physiology did.
Yes.
And so addressing the inflammation and that change in physiology is really important.
Yeah.
And again, when we look at that, that inflammatory response of ocular surface disease, that's again, what happens is we start getting that neural breakdown. We don't have that afferent message properly going to the central nervous system and telling the tear-producing glands, and that's when we start to see those breakdowns within this. So rate your level of confidence in identifying patients with neurotrophic keratitis.
So now we're talking neurotrophic, the health of those nerves and losing the
I
ability
think
for them to
this has
respond.
received so much education, in the last 5-6 years on neurotrophic, and I think that there's that differentiating factor between neurotrophic keratitis, because the first time this was ever brought up to me at an advisory board, I went to neurotrophic ulcer.
Yeah.
Not just a keratitis that is causing a breakdown and going to be progressive.
Well, it's to the point of anything. It's like, you know what, these are progressive diseases, and from that, it has to have a beginning before it gets to the end.
Yeah.
And we're always looking at that end.
And the neurotrophic keratitises that occur when there's been a herpetic infection, when there's been trauma, when there's been chemical introduction, those become very straightforward because it's one eye.
Yeah.
But when it happens in both eyes, and I think it's reflected in our audience talking about somewhat confident, only 30%, somewhat unconfident, 47%, not confident at all, 20%. So I think this is a good,
Yeah.
and
You
we
said
have a
that,
case on this
and they
too.
just changed it.
We have a case
So,
on this.
yeah.
So what is NK? It's just really the impairment of the trophic supply and trigeminal nerve. So what happens is it leads to epithelial alterations. The epithelium will change when it no longer has that trophic support, where the nerves are telling the differentiation for the stem cells to go into epithelial cells. And as we lose that, then we tend to see that breakdown occurs. And we have a number of different triggers. And again, the events like herpetic keratitis and burns and trauma, but chronic contact lens use, that's something that every doctor should be looking for. And the prolonged use of even topical medications, that's not as common that we see. And some of these are rare, but let's look at what's not rare in our practice. Let's look at patients with contact lenses, patients with diabetes, patients that have had corneal surgery. When we look at the ordinary instead of the extraordinary, we really see that there is a lot of these candidates that we have to rule out. And when I'm looking at NK, Mark, it's the case history that tells me so much.
Yeah.
And then I'm trying to rule something out at that.
Yeah.
Stages of NK, what we see, and this is so important, that the mild stage 1 that we get, it's a persistent PEK. It looks just like a dry eye.
Right.
That doesn't heal, that no matter what you do, it's not going to heal.
But also, the patient doesn't even know they have it.
Yeah, the patient is unaware of it.
They're coming in because they say my vision's blurry, or there's always a haze, or there's something. I mean, those patients where you have those real recalcitrant type of dry eye patients, then I think, in the next few slides here, we're going to talk about diagnosing this. You have to diagnose it.
Yep.
Because the stage 2, stage 3, the moderate to severe, the Mackey system, those are far and few between.
That's
those
severe
are rare.
disease.
Those are rare.
Yeah. And they're severe at that particular point. So we're going to look at the poll, rate your level of confidence in identifying patients with Sjogren's syndrome. Boy, we switch gears fast.
Yeah. Well, because we're just talking
We're going
about
to tie it all in
state.
together.
Yeah.
We're going to tie all this in together. And that is very confident with about 11%, somewhat confident, 44%, which I would think that the majority of people would live in, somewhat unconfident, not confident at all.
Yep, that's me. I clicked that.
It's a tough one.
Well, I am going to go back to one simple question that you told me to ask, Doug, and it's going to be on the next slide after this. Obviously, this is inflammation driven by autoantibodies and infiltration, and we see that 1 in 10 patients with dry eye has Sjogren's. Is a delay in our diagnosis. What's our next slide?
Well, and one of the delays in the diagnosis is going to come from we're just letting it progress until we really make that.
Yeah.
A key should really be if a patient shows up and they have water in the exam room, if they have a bottle of water, if they have a little hydro flask that they always have in, I'm always looking at that and saying, and then the question I'll ask that patient is...
No, don't. It's up on our slides.
Oh, okay.
It's coming
up. Okay.
Don't ruin it for everybody.
Don't ruin it. Okay. Yeah. Okay. Got it. And, some of the complications that we get are from Sjogren's syndrome or filamentary keratitis. We get corneal erosions, corneal perforations, vascularizations, and we
all
get
the real significant desiccating damage that we keep talking about.
Yeah, that we see this. So rate your level of confidence in identifying patients with keratoconus.
Ooh, is there a correlation between all these three? Maybe there is. I am going to go with
a yes.
Somewhat to very confident. Yeah.
Yeah. Yeah, I think this is...
Which is what the vast majority of us, and that's
the
good.
vast majority, yeah.
Good on you people.
Go ahead and cover the keratoconus.
Yeah, without spending a lot of time on this, we know that it's progressive ectasia of the cornea. More importantly, it progresses through the years. How we diagnose it, basically we'll talk about in a few seconds. But you just see worldwide, about 370 million at risk worldwide. About 63 million have keratoconus. So, it's pretty common in our practices. 20% of the refractive candidates have at least one risk factor for keratoconus. And I think refractive surgery over the last 30 years has really brought to light keratoconic patients. Whether it be pellucid, which is aversion, or whether it be just kind of form thrust, we kind of see more of these cones, if you will, because we didn't do a great job performing LASIK, and about 1 in 400 procedures had keratoconics, which we should have stopped. And more importantly, we just need to kind of be better about reviewing those risk factors.
In my opinion, because we screen so carefully and we look for abnormalities that are just not in the normal range or topography, that we tend to be very conservative, and we probably don't do a lot of surgery by far that we would have in 20 years ago.
30 years ago, definitely.
Yeah,
So.
I think that's really so.
So how are we going to diagnose these bad boys?
Well, let's talk about that.
Well,
diagnosing NK. So we're right back to NK again. And as I mentioned, the exam and history. If you see a patient that has diabetes, they've had corneal surgery, as they've been wearing contact lenses for years. Those are ones that you really have to consider, okay, could this NK be a diagnosis of this? And then I think, as Lindsay said, looking at lid function and blink rate, because that's part of the reduction in that message from the central nervous system, is in that trigeminal, you lose some of that mechanical blinking as that not only tear production, but they don't blink normally. They don't blink as often as well.
I'm going to challenge, you can go to the next slide, Doug, but I'm going to challenge our colleagues to basically do the due diligence that you do with like a diabetic patient. You're looking for retinopathy, look for neuropathy. Is that every diabetic patient comes in for evaluation is why would you not measure their, to kind of get a sense of what the corneal sensitivity is. Long-term contact lens wearers, why would you not measure to see what that sense is? Your glaucoma patients that are on medications, this should become just part of your clinical acumen, if you will. Just it should be something you just don't think about that you have to do. It should be something that you just do naturally, much like looking down for collarettes now. I mean, you know, for Doug and I, you know, it's literally just a matter of touching the eye. One of our colleagues, Cecilia Ketting over in Colorado, she uses the Cochet-Bonnet esthesiometer. You know what? She's bougie like that, and let her, which gives you kind of a objective measurement. I'm all about subjective, and I'm all about making it easier. And I think the next slide here
Well,
shows
and
you.
that's why I keep dental floss in every single exam drawer.
Yeah, here we go. This is me. I just wanted to get to me.
Well,
Why?
those hands look very familiar to the hand
You know,
model.
I'm not gonna lie, hand model here. So I used to, and I still do sometimes, I'll use a con-tip applicator. Not one out of Doug's practice that you cannot get a wisp. Doug, what was it? Was I pranked? Yeah, it was prank day, much like on Wednesday. How many people are watching Wednesday on Disney right now? Phenomenal. Or no, Netflix. So literally, look at that, okay? I get my little tiny wisp, if you can see it, and what I will do is I'll come at the patient, dun, dun, dun. See this patient? Look at the look on her face. She is excited, happy to be there. Okay, I'll grab her lid, but normally what I do now, Doug, is I'll just go straight in to the slit lamp. I'll say, hey, what's that over there, Wily Rabbit? And I'll touch their eye. You know, now you use what?
I use the
Look at her
dental
blinking.
floss.
Those are some. Look at the pores on her nose too, though. Can you see that? We need to talk to this person. All right, next slide. We've seen enough of her.
Okay, this is another method of doing, and this is what I prefer. And I would really recommend that in looking at,
Who?
yeah, this patient, you can tell, hey, they're responding right
What the fuck?
away.
What the da, da. Do you ever have a patient just kick you and go, what the fuck? Doug? Jeez.
Not often. Okay, here's a patient now that,
Has no sensitivity.
yeah, you look at that and she's just not responsive at all. The reason I really like dental floss is you can get in there, you don't have to use your hands on the cotton wisp and then struggle in front of a patient and look like you're incompetent in pulling a cotton wisp.
Pretty much. No, but to your point though, Doug, is the two things between the two videos that I think is really important. One is patients have a natural reflex to pull away.
Yes.
So if it hits their lid, they're going to pull away. But if you're just touching the cornea, you know that something happened, and that instant blink. Patients that have a very slower blink, or more importantly, nothing at all, then you know they have a reduction.
And, you know, right now, this is, I will say about corneal sensitivity testing. If you have an eye that has had a trauma or a herpetic infection, you have a control and you have one that's not controlled. But when you get bilateral decrease that we're seeing from long-term contact lens wear for diabetic patients, for those patients that have had corneal refractive surgery, I would really advocate just taking some dental floss and taking your healthy patients and just when you're doing the slit lamp exam, test the eye. And that's creating the baseline what normal is.
That's called practice.
Yeah, that's called
And that's
practice.
what you told me to do. You know, you talked about your Sjogren's. What's the one thing you do to diagnose your Sjogren's?
Well,
What do you ask them?
I asked the patient, are you able to eat a cracker without having a drink of water?
That is so brilliant, you know, because it goes to the heart of the oral symptoms. And I don't know how oral versus ocular symptoms, but you see patients with really dry eye. You see patients with, inflammation, that foreign body sensation. And then I ask them, can you eat a cracker without water? And they're like, no, not really. Yeah. I'm like, boom, I DeVries'd you. That's what I just did there. So yeah, totally.
Yeah, you're looking at the cornea. Obviously, the reason you're even asking that question to the patient is because their cornea doesn't look good. They have a lot of PEK. Every time you see them, they're still recalcitrant and not really responding as you'd like them to respond. But asking them that question, and then that will then lead to clicking a lot.
Yep.
That will then lead to looking at different tests to do. And I still use the very specific Sjogren's test as opposed to the SSA and SSB with the specific biomarkers called the SHOW test.
SHOW?
You can still do that and overlap because, you know,
How do you order that? I think, is that on the next slide? How do you order that?
well, what you have to do to order it, you have to say proprietary, specific. It's parotid, carbonic anhydrase markers as well, and salivary markers that aren't on the typical is SSA and SSB, and then they'll do NA as well. But on this, I will have the regular markers plus those as well. And most of the labs have to send it out because it goes to one specific spot in the country to do that. But if you put specific, you want the specific high sensitivity, then they'll do that.
Oh, cool.
And you get that back. So I think it's, and I think that really you have so many overlaps with these patients as you're looking at this. But fluorescein becomes very important, and looking at that patchy staining that you see, where little patches, particularly temporal, that you'll see on the patient's eyes, and it's clustered. It's clustered patchy staining that you see when we look at the lissamine green. And honestly, I don't. After the shortage of lissamine green, I really don't use lissamine green.
I loved lissamine green, but it's one of those things where I've been able to practice without it, so I'm going without it.
Yeah. Yeah, but the fluorescein, I'd be in desperate straits if we couldn't get fluorescein, because you're really looking for a lot. On the inadequate lid seal, you're looking for that inferior staining that you have. You're looking for the patchy staining on the Sjogren's patients. You're looking at the more diffuse staining. And then I think look at the conjunctiva. Yeah. I mean, seeing that, the mucin deficiencies that exist when you have a lot of conjunctival staining is very important. This is an example of that patchy staining that you would see.
Yeah. And I think that 2-minute mark that's right there is like, I think, you know, we're all very busy, and you know, you put the stain in, but you got to wait a minimum of 2 minutes.
Yeah. Yeah.
Really let that stain penetrate between the epithelial tissue, so you really get a good assessment.
What happens when you initially put fluorescein stain in, it overwhelms the eye and it'll cover it up. Yeah. You know, it's kind of like trying to find potholes on a road when it's raining hard. You're not going to see them. When it starts to dissipate a little bit, then you're going to see the individual pooling that you're going to find. Makes it a lot easier. I learned this during a phase 3 dry study, where you had to wait 5 minutes, and I thought, why would we possibly?
It's
have
all
to
gone. What are we going to do?
5 minutes, and as a result, you really saw what developed in that amount of time. So
100%.
The assessment staining is real. And Mark, tell us how you use confocal microscopy.
I don't
in your
really do a
practice.
lot of confocal microscopy, especially as it pertains to the Sjogren's, but it is something you absolutely can do to look for those immune inflammatory tissue.
And if you're in a research practice, you can do it. I don't do it as well. So when to use the Sjogren's diagnostic test and look for those specific biomarkers is when you really, and sometimes the sensitivity and specificity of the regular Sjogren's test is going to be about 50%.
Yeah.
So that's kind of a coin flip.
Yeah.
With this, you're going to be hitting in the 90% sensitivity and specificity to really identify it about 7 years sooner. So if you're questioning, and this just now, is it going to make a difference on how you're going to treat the patient? Probably not, because you're going to go all out using amniotic tissue and using nerve growth factors and things like that. But it really will help you also with some of the approval for these things.
But also patients want to know.
They want to know.
They want that definitive diagnosis. So yeah, it's all great.
Yep.
I mean, I think with keratoconus, you know, obviously topography, tomography, you know, look for some of those normal signs. I think it's pretty apparent. I mean, anybody who's not getting a good refraction, remember we used to do the doctor-killing refractions or the scissoring. I think you just need to look for these earlier on patients, especially.
Yeah, and you know, our tolerance for looking at a normal topography and then seeing skewed axis, seeing inferior steepening of any kind, looking at that really has been much. And I think, you know, when we're looking at using specialty contact lenses, that really plays well into that. You might want to start that patient sooner in a rigid lens. You might want to look at scleral lenses for that patient because of that, if developing at an early age.
I still think there's no such thing as Munson sign. So I'm just
still haven't seen it. Huh?
No. Have your patients look down. There's no Munson sign. I think. Anyways, yeah. Move on.
Still waiting for it.
Still waiting for it. You know, for me personally.
Okay. Again, the topography and looking, and this tells you so much, and that's where there really is a beauty in a manual keratometer, and that you can look for overlapping, you can look for irregular Myers, and that placido image will tell you so much.
Yeah, the placido rings are the best. Ooh, we have another audience poll question.
How confident are you in differentiating between different cyclosporin treatments and your understanding of maximizing patient comfort and tolerability with these treatments? This is so important.
Yeah. I'm gonna go with, I don't want to be cocky, so I'm gonna say somewhat. Yeah, that's what I'm gonna go with.
That you're somewhat, or
Yeah, me,
okay,
yeah.
okay.
Although I can't do it all. I mean, I just want to make
You're just
people
being
feel
humble.
good because somebody put they're not confident, and I just want I feel you people out there.
Yeah, and what we're finding the majority of respondents
13%. Wow.
is it's somewhat confident and minimally confident and some not confident at all in terms of different. And it's confusing because what the insurance companies will tell you is it's all cyclosporin.
Yeah.
And it's so far from the truth in that. So let's take a look at that. Here's what we have in terms of anti-inflammatories. And it's interesting, before we get to the last one, we'll kind of go through the true immunosuppressives, and that's the cyclosporin 0.05, lifitegrast 0.5, cyclosporin 0.09, cyclosporin 0.1%, and corticosteroids, which we've used for years. And then as we look at perfluorohexyloctane, that really is way up on the chain,
Right.
hoping to prevent inflammation.
Well, these say anti-inflammatory, and so I think to your point, at what feels like forever ago, people, I know it's been 2 hours. Trust both of us, our bladders are telling us that. But, you know, you guys are doing what you do out there, okay? You know? Is that very, very early on we talked about evaporative. And that if you don't control the evaporation, if you don't do something, then you're basically going to have that desiccating stress, which then in turn induces inflammation. And so slowing down that evaporation is so critical. So I do see where perfluorohexyloctane is here because it's the only FDA-approved medication that targets evaporation. And I love that. But when there's signs of inflammation, Doug, we need to work on the inflammatory aspect.
And we talked about that earlier. There's a very fine line between evaporation and inflammation. At what point does evaporation then become inflammatory?
Right.
Because what we see is we see downstream activation of the active and inactive T cells causing cytokine release, perpetuating the whole inflammatory cycle.
What I like, if you go back to that slide again for a real quick second, Doug, is that, you know, I don't use 0.05% cyclosporin anymore. And for two reasons. One is because, you know, 0.09% cyclosporin has been demonstrated to show a much better significant concentration of the cyclosporin. And more importantly, we have 0.1%. The 0.09% and the 0.1% of both of those cyclosporins, to me, have a much better mechanism of action. I mean, excuse me, a mechanism of delivery. And I think you cannot lose sight of the fact that, you know, it's easy to sit there and say, oh, I'm going to put you on like a generic and make that part of your day because it's easier. But I think patients will pay a little bit more if you give them what's in it for them. And, you know, using the N-cell technology with 0.09% that you see from Sun Pharma, or using the perfluorobutane, perfluoropentylbutane that we use in the Hero product, which is Vivi, I think both of those are emblematic of advanced technology to reduce the inflammation.
Well, and it's all about method of delivery.
Yeah.
It's not mechanism of action, same
Right.
mechanism of action, but if you can get 3 times the amount of the drug in a higher concentration to the responsive tissue, then it makes sense that you're going to get something. And I totally agree with you. Don't settle for insurance companies just say, we're just going to put you on generic. We're going to put you on 0.05. I mean, if we can, and all of these companies have strategies to be able to get the product to the patient at an accessible cost. Describe the N-cell technology.
Well, real quick, you know, obviously the cyclosporin hates being in water. It's hydrophobic. But more importantly, what it does is it likes
That was
to...
never obvious to me.
Yeah, pretty obvious. Yeah, so, but more importantly is that if you encapsulate it in basically these micelles, which basically can then penetrate through the tissue, then you open it up, get it into the tissue and go there. So it's almost just like it's a Trojan horse, if you will. So it makes these little nanoparticles and basically kind of takes that hydrophobic cyclosporin and brings it into the tissue for those concentrations.
Yeah, I mean, it just simply takes a very small molecule and makes it hydrophilic.
Yep.
And so it's going to want to travel through that tissue. And that's why we end up with 3 times the concentration in getting to the target tissue.
Right, and which is important.
Which
Yeah.
I can think big. Okay.
Yeah, there we go. So like you just said though too, and there was a study that they did where they took patients and put them on 0.09%, and they found that they were way more comfortable. 95% of the patients experienced mild to very little sight installation pain. And that's exciting because a lot of these patients, you don't want an extreme side effect. They're not going to stay on a chronic medication, you know, for a prolonged period of time if there's a lot of side effects or if there's a lot of discomfort. So having something like this nanomicellar technology combined with the 0.09% means they're going to stay on it longer too.
Right, right. And that's what we want, is we want longer treatment time to be able to affect what we're looking for in controlling that inflammation. And what the cyclosporin does is really inhibits that T cell.
Right.
It inhibits the cytokines, inhibits the inflammatory process, which is damaged as a result. And I tell patients all the time, if you sprain your ankle, no one's going to tell you just go out and run on it, it's going to get better. No, you got to rest it, you got to do something to stop that inflammatory process. And that's what this does in the eye, is it stops that inflammatory process.
But when you talk about comfort, Doug, hit your next slide, okay? You know, there is nothing that can be said about these semifluorinated alkanes about discomfort, because patients don't even feel them.
Right.
And so combining this semifluorinated alkane as a vehicle, which is the perfluorylpentylbutane, combined with the highest concentration of cyclosporin, has really set this drug apart. And it's kind of, you know, it's exciting to me. I mean, because of, you know, we can read the slides here together, this amphiphilic nature of the SFAs, you know, it basically dissolves in that hydrophobic drug like cyclosporin into the tissue and brings it right into those higher concentrations. And more importantly, you see here that it's detectable in tears for up to 8 hours.
Which is amazing. When you're talking about perfluorobutylpentane, it's a vehicle. It's a method of delivery. So where N-cell technology is used in 0.09, in 0.1%, it really is, again, same molecule, but get it to the target tissue. Get it into and let it penetrate.
But the other thing too is if you look at any of the SFAs, especially perfluorylpentylbutane, it spreads. So it has that, kind of creates like a low viscosity, so it can penetrate into the tissue. And you can see some of the bullet points here. This is the first and only cyclosporin combined with perfluorobutylpentane. We see for the treatment and signs and symptoms of dry eye, we see that it's clinically and statistically significant. Improvement at day 15, which is nice, that it's fast. There's no pH or osmolarity that's associated with this. And lastly, it improves the tear film and comfort. I cannot emphasize enough that I see a lot of patients who have inflammation, and the patients aren't symptomatic. You know, they're not coming in and saying, my eyes are killing me. Those are easy to treat. Yep. And I say they're easy because you put them on something that has a little bit of side installation discomfort, or maybe, you know, some other, you know, ancillary side effects. They're going to tolerate those. But for the vast majority of our patients, they want something seamless and comfortable, and yet also having the efficacy of something like this 0.1% that we see here combined with perfluorobutylpentane.
Yeah, I mean, it's really the rise of the semifluorinated alkanes.
It really is.
And they're, you know, different. They're short, they're long chains, but what they're actually doing, one is acting as a protective covering over the tear film. The other one is acting as a means and a method of delivery.
Right. But the interesting thing about that, Doug, is you know, here's the studies that were done by Harrow. You see Essence 1 and Essence 2. We see, you know, significant improvement by that day 15 on that line there, all the way out until day 85. Good, nice separation there.
And this is comparing cyclosporin in the same concentration with and without the semifluorinated alkane.
Yeah.
And that's pretty impressive when you're taking 0.1 and then you put it into a different method of delivery. Right. And the efficacy that you get from that.
And that's total corneal fluorescein staining too. So, which to me, those are patients who have significant amount of dry eye.
That's significant, yeah, when you're starting
to see that. Because when I see staining, I think inflammation. I think something anti-inflammatory.
Yep.
So
and controlling that inflammation, and we know that cyclosporin has a proven history of being able to take care of inflammation. So if you can get a higher concentration
Yeah.
to the patient, to the target tissue.
So what's the summary here? What's the summary, Doug, on the impact of this?
We know that perfluorobutylpentane can also improve the lipid layer grading, which may also play a role in reducing tear evaporation. So I think that's an important aspect, that potentially is causing that decrease in evaporative.
And it's interesting to say that because last night when I was bored, I just pulled out the TFOS Deuce 3 in the management and therapy report, and that was noted in there. So yeah, I'm going for that.
Yeah, as noted in that, that it could perhaps, So
Yeah.
so that, again, getting into the semifluorinated alkane and really improves the tear fluid lipid layer thickness within minutes after installation. So these are important aspects of the other semifluorinated alkane that's being used as a vehicle.
Yeah, so it can really, has an opportunity to help maybe reduce tear evaporation as well.
Yep. So let's talk about treatments for neurotrophic keratitis.
So it's interesting, Doug. If you look at this slide, I'm going to tell you right now that 2 of those are management and 1 of them is a treatment.
Yep.
And, there is, for me, an amniotic membrane slows down the symptomatology of it, but it's not managing the condition. So I'm working on symptomatology. I basically will use the amniotic membranes. I've used them more now, probably in the last 2 years than I have in probably the last 30 years. And part of the reason why is, you use those acellular dry amniotic membranes, especially as kind of like almost like a shield, but they're easy to use. They're comfortable for the patients. The cryopreserved amniotic tissue, as we talked about this yesterday, off-label here or off-line, I reserve those more for my central, those patients that have more significant central. But treating NK, there's one treatment and one treatment only, and that is Cerninogen BKBJ. It is the only treatment approved by the FDA. So much like, when we talked about Demodex, there's one treatment that's approved by the FDA, Lotilaner. Here, Cerninogen BKBJ, which basically is the only biologic that we actually have, that recombinant RNA to bring back those neural growth factors.
Now,
did I miss anything, Doug?
No, but I'll put a little spin on it for you.
Spin it.
And that is, I use the cryopreserved amniotic membrane, but I also used it diagnostically with NK, because you have these patients and you're trying to manage, you're trying to get it healed. But those patients that are NK don't respond the same way to an amniotic membrane, a cryopreserved membrane, as somebody who doesn't have NK. They look healed, they look better, but in 3 weeks they're right back to where they were. They're not improving for 3 months. They're not continuing to have good looking corneas. So I use that as a starter, and then we'll move directly into nerve growth factor.
Yep.
Because it really becomes diagnostic. It's kind of like the last proof for me. I know it is. I see that they have decreased corneal sensation, but when they respond like that, so to amniotic membranes, I know that there's a lot deeper problem than just the epithelium not healing.
Yeah, very cool.
So then of course,
I learned so much from you, Doug. I do.
The treatment, of course, is Cerninogen.
Cerninogen.
You're doing very well with
Thank
that
you.
now.
I know I had so much trouble with that before. Do you remember that? And it's like, can somebody tell me what BKBJ stands for? In the comment section, I would love for everybody to tell me what they think BKBJ stands for.
Okay?
And keep this G-rated, people.
And you know what it stands for.
Yeah, I do, but I'm not going to tell you.
So Cerninogen is nerve growth factor.
Yeah.
Oxybate, where you, and what it actually does is it's a bioidentical nerve growth factor, and it produces more nerves. And they have that in looking at corneal sensitivity and looking at nerve growth factor. The interesting story with the person that actually discovered the nerve growth factor, and that she never saw it commercialized, and she lived to like 103 years old. But her discoveries led to a Nobel Prize in medicine. So
it was for pancreatic cancer, wasn't it?
Yeah. So really saw that, and I think what you're going to see is this molecule used in a lot of different other aspects of medicine as we go along. So in terms of the trial, This really is the capsulation. There were two different trials. One was the Reparo trial. The other one was the U.S. trials. And what we saw was 72% of the patients in clinical trials had complete corneal healing.
Yeah.
And I think the impressive number is 80% of those that had complete corneal healing remained completely healed for 1 year after stopping the therapy.
Crazy.
Yeah.
Crazy.
And I know
And we're talking about stage 2 and stage 3 where there's an erosion or there's an ulcer. This isn't just like, oh, SBK.
Yeah, this isn't the stage 1s that are involved. They had to be stage 2 or stage 3. So they were a persistent epithelial defect or they were a neurotrophic ulcer. And to see this kind of healing is pretty amazing. So if you introduce it when you have earlier stage of neurotrophic keratitis, a real advantage to that patient.
Slow down that progression.
Yeah.
Hell yeah.
Yeah. Stops that.
Remember I told you I was going to say hell yeah? in
You
this
did.
lecture?
You said you
I
were
just
going to get
did,
that.
yeah.
So, Mark, tell us about the 4-year retrospective.
Yeah, so remember, this is just 8-week treatment. They observed these patients over 48 months, and they found a statistically significant improvement, visual acuity, tear production, in all their different markers, 1 year, 2 year, 3 years. So the sensitivity basically improved 1.5 times from baseline. It really demonstrates that, to your point, Doug, is that if you take these patients, then you're doing something that has, prolonged effects. Because there are obviously, maybe, we talked about before, systemic reasons. There may have been just mechanical reasons. But being able to regenerate that nerve factor and basically put these patients in a better position is just phenomenal.
And while we look at corneal healing, and that's very important that these patients don't progress, remember what you're doing is you're getting the corneal healing because you're increasing the neurotrophic supply. So the central nervous system sends that down, regulates the tear production, regulates the blink, and then also assists in healing that for the differentiation of the limbal stem cells into epithelial cells. So the healing is secondary to that communication that you get with the nerves.
I could not have said that better.
Well, I think we have another correspondent coming up here from our iNews correspondent from Sioux Falls, North Dakota.
From the wild plains of South Dakota.
South Dakota.
Oh, up there. You betcha. Got to bring in Mitch so he can give us a little
Mitch
case
Ibach, and
report.
he's going to give us a NK case report. Mitch, how you doing?
Welcome back to the Eye Report. This is case number 3. Turn down the lights. I'm Mitch Ibach. I'm an optometrist with Vance Thompson Vision in Sioux Falls, South Dakota. And so here's our patient. This is a 73-year-old Caucasian female who was referred into our practice. Chief complaint of blur, blur, blur. Left eye more than right. This patient denies having any pain in the left eye. This patient's seen multiple providers, but is quick to tell me she hasn't gotten any relief. No one's been able to make this better. Past ocular history, cataract surgery with an IOL in 2013, an upper lid blepharoplasty in both eyes in 2016. The patient had a PTK, or phototherapeutic keratectomy, in the left eye in 2017. This patient has chronic dry eye, and she's been treated for dry eye for many years. Mild primary open-angle glaucoma in both eyes, taking 2 topical agents, being latanoprost, a prostaglandin analog, once a day in both eyes, and then an alpha-2 adrenergic agonist with brimonidine twice a day in both eyes. And she notes, I've taken glaucoma drops for many, many years. Patient's also diabetic. She notes that she has poor blood sugar control. She was unsure what her HbA1c was and is currently on insulin. For ophthalmic or ocular medications, cyclosporin 0.05% twice a day in both eyes, and then preservative-free tears in both eyes. And during the history, this patient says, can we take a break and turn down the lights? This patient wants it dark in the exam room. Continuing with entrance testing for the left eye, it's important to note this patient comes in wearing habitual glasses, and so best corrected spectacle. Visual acuity this day was 2250 in the left eye. The patient does pinhole to 2100. Interocular pressure of 13 by Goldman applanation tonometry in the left eye. As background, I was able to obtain the referring doctor's visual fields and OCTs previously done at a different practice, and this is overall very mild glaucoma. Slit lamp exam in the left eye, lids and lashes, mild blepharitis. We have a clear conjunctiva in the left eye, and we see this corneal photo to the top right. On the cornea, we have this central depressed lesion. It has a sunken in appearance, maybe 20% depth, rolled edges around. It measures 3 millimeters horizontal by 1.5 millimeters vertical, and we do have an epithelial defect with surrounding punctate keratitis. The lens, posterior chamber IOL with a clear capsule. And the next step for me for this patient was I got a non-preserved artificial tear vial, opened it, wet a sodium fluorescein strip, and put it into the eye. Here's what we see, this central epithelial defect here. And so my next step for this patient was to check corneal sensitivity. A big key to checking corneal sensation and looking for neurotrophic keratitis is to check corneal sensation before any anesthetic goes in the eye. The way that I like to do this is shown in the picture to the top left. We'll get a sterile cotton-tipped applicator. I'll wash my hands before I do it, kind of wisp out the cotton. And then I like to check what I think is the unaffected eye first. I like to check central, superior, inferior, nasal, temporal. We're looking for both kind of the objective lid blink response as well as subjectively asking the patient if they can feel it. And my grading scale is really just absent corneal sensitivity, 50% reduction, or full or normal corneal sensitivity in that spot. And so we checked the right eye first, and then came back and checked the left eye, looking again for a reduction in corneal sensitivity. In our practice, we also have the picture shown in the middle, which is a Cochet-Binet aesthesiometer. This is a more quantitative test to look at corneal sensitivity. You fully extend out this filament, you check the patient's corneal sensitivity. If they don't feel it, you withdraw the filament back into the device. As it gets shorter, it becomes more firm, and you're trying to get a quantitative result for corneal sensitivity. And then a final way on the bottom right is using sodium chloride or using a hypertonic saline to ask patients, does it sting and burn, again to check corneal sensitivity. And so for this patient in the left eye, we had the loss of corneal sensation in 3 quadrants, central, inferior, and nasal, and reduced sensitivity temporal and superior. We have a persistent epithelial defect. We have an open epithelium that was noted in the charts. And so now we have a loss or reduction of corneal sensitivity and this open epithelium. And so by definition would be stage 2 neurotrophic keratitis in the left eye according to Mackey classification. And so that's our diagnosis for the left eye. We also have chronic dry eye syndrome with an eyelid margin component.
Wow. Got a new pull. Yeah, seriously. Mitch, you took everything we've been talking about NK and put it into one case. And I have questions. I got questions for him, but let's do a
let's
poll
start
question
the
first.
poll. Which diagnostic approach would you use based on the case presentation? And vital dye or stainings, lid function, blink rate, corneal sensitivity test, and review of previous treatment results. That could, again,
Could be all of the above.
be all the above.
I know. I love how we challenge people to just choose one answer.
Yeah.
Too bad, suckers. Got to choose one answer. What would you do, Doug?
All the above.
Yeah.
Yeah. I mean, you're really going to base it on past treatments. You're going to do corneal sensitivity testing, but I think that's going to rise right to the top to really give you a clue to begin with. So let's.
Hey, Mitch.
There's Mitch. Here he is.
Hey guys, how are you?
Good. Thanks for joining us. What a
Great case.
Good case. Yeah. I have a question. Okay. So first and foremost, you're talking about managing it. And how often do you use the hypersaline solution to kind of diagnose that?
Yeah, so I personally haven't used that, but some of our colleagues have talked about really liking that approach. It's in the literature, and so I wanted to be complete there. I'm a sterile cotton wisp, so I've been learning alongside you guys during this, and so I was listening. You guys have different approaches. I've used dental floss. I use a cotton wisp now mostly.
So it was interesting because in the picture that you were showing in your case, it looked like the cotton wisp was hitting the lid. So you were really going straight to Doug, which kind of like screwed us cotton whispers over here. Man. So I'm curious to see how you manage this patient. So I'm excited about that.
Yeah, let's take a look at that.
You can tell us.
Yeah, so for this patient, continued cyclosporin, I think it's important that we have, continuing that for inflammation. One of the things that this patient didn't have coming in, which I think is really important, whether it's NK, whether it's recurrent corneal erosion, whether it's something else where we have an open epithelium, is we want to have some antibiotic on board. And so I want to try to prevent a prophylactic infection here or an opportunistic infection. For this patient, we do a lot of punctal occlusion in our practice, and so trying to maintain more natural tears on the eye. And then you guys talked a lot about this, Sirnegimen BKBJ. This is a very, very efficacious medication, and so definitely wanted that on board. I think one of the truths with this medication is patients don't start it the day that you prescribe it, and so you do have to have a little bit of a bridge plan in there. And then finally, we're a glaucoma practice as well. And so interventional glaucoma approach for this patient, try to lessen the amount of preservatives on the ocular surface. One of the etiologies that could have been causing the NK, or at least contributive to that. And so want to lessen that so that we don't break open in the future.
So I'm curious, did you use in that bridge therapy, did you do an amniotic membrane? Did you do, what did you guys do?
Yeah, I didn't do either a bandage contact lens or an amniotic membrane graft for this patient. I do use a fair amount of amnion in patients with NK as we're bridging. I didn't for this patient. It had been going on so long. The patient wasn't uncomfortable, had a good seeing contralateral eye, and so didn't for this patient.
Yeah.
Well, it's remarkable when you look at that visual acuity difference, and I think that that's what you see in response to treatment with Sirnegimen is looking at that 250 to 2070 to 2040 in 8 weeks, and the difference in that cornea looks amazing.
Do you, when you're using Sirnegimen BKBJ, do you notice that patients, that's what it's called, Doug, okay? Jeez. Do you notice that the patients start to get some discomfort, maybe some, I noticed the blurred vision. Is that pretty common you're seeing with patients?
Yeah, I think at least a coin flip of my patients will have some awareness, sensitivity, discomfort from it. I think all of us kind of take that approach of we're going to try to spin that positively of maybe we have some nerves that are firing now, so this is a good thing. That's what I tell patients, at least, to try to keep them going on it. And I think to Doug's point on visual acuity, that's maybe one of the things that's underappreciated in some of the literature that you guys reviewed earlier on this today is I have a lot of patients in my clinical experience who see better after using this. And so the acuity part is fascinating.
Yeah, it's awesome.
Yeah, and it's interesting in terms of one of the side effects that they listed this as potential some ocular pain. And it's very unique in my experience. The ocular pain is kind of a deeper, almost like there's a, more of a closed angle type of thing, but not necessarily in that the patients, they seem, most of them are not severe. Most of them can tolerate. I've had very few patients that have had to discontinue because of that pain. But when a patient comes back and they report that kind of a deep pain, that's a pretty normal thing. We tell the patient they may expect that and only, and report it if it's severe.
Yeah. But, Mitch, are you using this treatment more than you have probably in the past, like for stage 1? Are you finding yourself gravitating a little bit to managing those patients, or are you still kind of reserving for stage 2 and stage 3?
Yeah, most definitely. And so probably 70% of the Sirnegimen that I prescribe for patients is in stage 1. I think that's credit to the doctors in our kind of referring network. They're getting these patients to us early. We're much more aware of testing for corneal sensitivity now, and so we can get to these patients earlier on. And so, yes, most definitely a lot of stage 1 in my practice, and then, works very well in stage 2 and 3 as well.
Yeah.
Mark, how about yourself?
Yeah, I mean, I think people need to understand this is a rare disease. I mean, seeing stage 2, stage 3 is the rarity. It's stage 1 is not that rare. And so I'm seeing, I'm probably closer to 80-90% stage 1, but I'm not holding back treatment because of all the nefarious kind of sequelae that we see that happens from NK that I want to give my patients.
So you're not going to give it the opportunity to turn to a stage 2.
Correct.
Yeah, perfect.
Correct.
Perfect.
Yeah. So Mitch, I would tell you just, when you think of stage 1 patients, look at yourself in the mirror and just think, cyanogen, like the cornea, like your hair in your head. You know, stop the progression. Stop the progression.
I've witnessed the whole progression.
Yeah, you have. Yeah. I'm not bitter. I'm not bitter about it, but wow. So here's 6 months after the treatment.
Yeah, and so ultimately, these patients, I think of kind of my number one goal with a stage 2 or stage 3 patient is to get the epithelium to heal over and ultimately close. And so we were able to maintain that for this patient. You can see we maintained much improved best corrected spectacle visual acuity. So this patient overall was doing well. Again, has a well-seeing contralateral eye. And then we did move forward with laser trabeculoplasty, again, trying to lessen the amount of topical glaucoma drops that this patient was on. And so just another approach to try to help the ocular surface for some of these NK patients.
What a great correlation between using like MIGs and contact lenses and other opportunities to help patients, and it's really dry eye to help kind of maintain that good quality of life. Yeah, have you felt or have you seen patients, because in the clinical trials, obviously, it was around 70% of patients were, they got epithelialized. Have you found that there's been some recalcitrant cases where you have to give them a second round of Oxervate?
Yeah, I have. I agree with you. I think that's the minority, maybe 10% of the cases that I prescribed for. And some of those were kind of bordering on that stage 2.5, stage 3, and just had much more aggressive causative factors for them. And maybe an incomplete lid closure. We're fighting multiple things at once. They would break back open on us.
Definitely. You too, Doug?
Yeah, I totally agree. It's a rare, but sometimes you have to, and those are really, really tough cases. And I don't hesitate to do that. A question I'd like to ask you, Mitch, and Mark as well.
No, just ask Mitch. I'm just, Mitch is our correspondent.
Okay, he's
coming from Sioux Falls. He came all the way from Sioux Falls.
South Dakota.
Sure.
So, the question is, how often do you treat bilaterally?
Yeah, bilateral treatment is probably maybe 10% of cases for me. I think if I'm going to treat both eyes, I'll usually do one eye at a time. I don't have a great reason for that, but that's how I've kind of done it in the past for some of these cases. But most of mine have been an etiology that's maybe not your diabetic patient. There's something significant going on one side, not the other.
Okay, so those are patients that had a reason, like a herpetic infection or some type of injury or chemical, or and I find that as well. It's just that is in your dry population that advances to neurotrophic keratitis. A lot of times I'll see those, but I agree, most of the time you treat them individually. You'll take the worst eye and start them on the Oxervate. Mark?
Yeah, no, I'm the same. I mean, to your point, Mitch, I mean, I think anybody who has zoster, I mean, you have to start thinking, looking for that neuropathy. And I think patients who have had, whether a stroke or trigeminal neuralgia, I'm thinking more along lines of that, monocular. But the diabetic patients, patients who are on glaucoma medications for both eyes, contact lens overuse, I'm thinking I probably have 20 to 30% more bilateral. I think I'm a little more aggressive than you, Mitch. You seem a little bit more reserved just in your personality, so I wonder if that kind of goes in the lane. I'm like a china in a bull shop. Bull in a china shop. Yeah. I couldn't see the trees to the forest or the forest to the trees. I still don't know which way that goes. Yeah. So, but you know what I will say is that Dompe has made prescribing this medication and getting it into our patients' hands. It is a process, and you said that before, Doug, but they have done a phenomenal job helping us as clinicians. So if you've never used it before, then hopefully, listening to Mitch and his case is going to give you more confidence that you have a tool that is going to manage the only treatment that's approved by the FDA for neurotrophic keratitis.
Yep, important aspect, that's for sure.
Yeah, totally. Mitch, I cannot thank you enough because
thank you so much.
You gave Doug the opportunity to go to the bathroom. And that was important because it could have been really, really ugly in here, but we really appreciate your case. And also, more importantly, I appreciate what you do for our profession. You're a shining star, man.
Thanks, guys. Appreciate it.
Appreciate our correspondent from Sioux Falls, South Dakota.
Sioux Falls, South Dakota. All right, we're going to skip our questions and answers. Why? Because I'm going to be honest with you, we don't care. No, is that rude? No, I'm teasing. We're just moving on. So
we're going to talk
it's our last section, Doug.
About what?
This is our last section.
No way, it's last
Yeah,
section.
I know.
Wow, time
We're
flies.
hoping that you guys might want to just stay with us until, I don't know, a couple more extra hours. Nah, we're kidding.
So let's talk about chronic ocular pain,
versus
ocular surface pain versus neuropathic pain.
You know, I think we should start off this section by basically just saying, what a pain.
What?
Oh, yeah. So COSP is a new definition.
It is.
You know, I mean, is it new or is it just a different way for us to kind of like discuss that patient that comes in with that really unusual, just kind of overt discomfort, you know, chronic ocular surface pain. You get that feeling of originating from the ocular surface. It lasts for more than 3 months, and I think that's critical too. And it affects patients' quality of life. Now, it's you know, when we start thinking about that, it is associated with those nociceptive receptors that are on the outside of the cornea that we just talked about. It could be some neuropathic inflammation or basically a combination of both.
Well, and I think, Mark, that, you know, that lasts more than 3 months, that's a key
Yes.
right there. But the other thing that should be a key is when you get through looking at the patient and what comes to your mind is it doesn't look that bad.
Yeah.
That it
Yeah.
doesn't, it's not commensurate with what the patient, and, you know, previously I think we just said, okay, that patient's a complainer,
Totally.
you know.
In our practice, we use white charts. A white chart is, oh, hell no. Somebody else needs to see that patient, right? Because nothing's right with that patient. Now I'm starting to think maybe they're a COSP.
Yeah.
You know, but remember, we also differentiate neuropathic, you know, from neurotrophic, because as you said before, neurotrophic patients are, you know, stain without pain. Neuropathic patients are the exact opposite.
Just exactly
You
the
know,
opposite.
they're pain with no stain. And so this is a disturbance or an insult to the nociceptive system. So it's more, not so much peripheral as it is internal. So, right, more
And it's not unique.
Deeper
It's
central
not
nervous.
unique to just the eyes.
right.
Neuropathic pain can occur in a lot of disease process, and that's what we have to consider, that those patients have that when you say, hey, it just doesn't look that bad.
Right.
And those are the patients that, because at that point, those patients have been very frustrating to treat.
Right. I think it's also interesting too that it's like we probably see we see more of these patients than we realize, because
I believe so.
Yeah, it's like when somebody comes in with a foreign body sensation, you know, your thought is, oh, put lubricating drops on it. It's not really solving anything. We maybe move to a different lubricating drop. Maybe we put them on an immunomodulating anti-inflammatory drop when we're not really diagnosing the fact that it might be some form of this nociceptive pain, discomfort that's associated with kind of almost a form of COSP, which is the best way of talking about it, you know? Here you see a list of all the etiological factors associated with COSP. It's a kind of a busy slide, but the truth of the matter is that it's environmental. You know, it could be autoimmune, anti-inflammatory. It could be neurological. I mean, my favorite is iatrogenic.
Yeah.
You know, shit happens. You know what I'm saying, Doug? I mean, you know, this is an adult CE. Shit happens.
Yeah, it does. But when we take a look at this, we look at the overlap
Yeah.
with so many other ocular surface
Yeah, good
disease.
point.
I mean, with neurotrophic, with dry eye, I mean, all of these factors can certainly be a part. And I think that's what makes it difficult, is you don't have a very specific etiological factor that you can go, oh, well, you know, that's neuropathic.
Yeah.
You know, I think that's where the mystery, and I think that's where the white charts came from.
Yeah.
Is
yeah.
where, you know, not really, but certainly, you know, you see this and, oh, does it affect the quality of life for individuals?
I think we sometimes lose sight of the fact is I do. I mean, I think you become immune to listening to patients complain because you just think they're coming in just to complain. And, you know, it really just kind of impacts everything they possibly can do. And it's like, you know, you start looking at the lifestyle, difficulty in driving or managing, you know, reading, being on a computer or things that they'd like to do. And but I think the bigger one on there is sleep.
Yep.
I don't think we realize how much dry eye itself or even chronic ocular surface pain impacts sleeping. And I've started kind of, you know, I have a spouse who is going through the change and she's not sleeping well. And that just really, it just affects every aspect of her life.
Mark, you mentioned dry eye and how it affects sleep. Well, there's now some papers written by sleep doctors that absolutely take a look at things like inadequate lid seal and the irritation that causes it as it advances, and how that can dramatically affect sleep, and then what other impacts, how that impacts the rest of the body.
Yeah,
because
100%.
sleep deprivation is really a lot. So when you're looking at this affecting the quality of sleep, that's a big factor.
Totally. And then it puts you in spirals of depression, and, it affects your social life and appearance. So, COSP is something that I think, diagnosing it and managing it is something we have to put on our radar.
I think so. I think it's one of those things that, and I think you see these patients and they've gone to multiple practices.
Right.
Because there hasn't been an answer.
We'll send them to Cory's practice in Cincinnati. So how do you diagnose it, Doug?
Yeah, I think it's one of those things that, first of all, it just doesn't look that bad. And these patients, it's over 3 months in duration that it hasn't resolved. And as you start to take that medical history on patients and realize that they haven't responded to other treatments. And I think that's where, when we're going to take the neuropathic, we're probably going to go down the very comprehensive route of chronic dry eye disease and taking care of that. Versus these patients, we've tried a lot of different things. They don't tolerate contact lenses. You really have some.
I've kind of resolved too that it's like, using something like proparacaine, where you're actually kind of alleviating some of the nociceptive receptors on the outside of the eye. You can maybe correlate that to COSP, as opposed to, if it doesn't relieve that, then it's more central nervous, which is neuropathic. And maybe that's a simple way of doing it, but that's kind of in my mind's eye, how I'm kind of trying to help differentiate the two.
I think that can certainly give you a lot of information on how they respond to that, because, those patients you've always questioned that when that's happened. It's like, okay, maybe this tetracaine is old.
Yeah.
Totally.
Maybe. Yeah, it's like, what do you mean you can still feel that? So, yeah, cray.
Yeah. So let's take a look at the, some of the treatment options that we have, and then we'll take a look at some of the newer suggested treatments that we have as well. But on the, we've talked at length about some of the different treatments that we do for the nociceptive pain with those patients, because we're trying to get those, the autologous serum eye drops, the amniotic membranes, started lubricants, and moving on then to shields and scleral lenses and those type of procedures that we'll do on, or lid procedures, doing temporary trasarphes and those type of. When we get to neuropathic pain, really we look at the beginning and it's a lot of the same thing.
Yeah.
It's a lot of the same thing, and the difference is they usually just don't get that response.
I think that, from a topical standpoint, we're really just kind of scratching the surface with the neuropathic patients. I think it has to be more systemic, those interventional treatments, maybe even some of the non-pharmaceutical, which, I don't know, hypnosis, things like that, but it's like a deeper inflammatory response. To me, where I think we should focus on is the nociceptive, or the ones where it's more peripheral. A peripheral discomfort is things that I think we can manage a little better. And I'm going to throw something out there, Doug, is that anti-inflammatories, like lifitegrast, right? It's coming up on their 10-year anniversary. Or even using some of the cyclosporins we just talked about, the 0.1%, using perfluorobutylpentane. Those have to be humming in the background. Those are ones that are helping reduce the inflammation. But I'm also thinking something like a triptyr, is bringing in accoutrement, which is a new medication that was just approved. Because what that's going to do is at least get those nerves firing a little bit, opening up that TRPM8 receptor and seeing what that might possibly do to kind of help reverse this, at least keep the eye more lubricated. Am I wrong in thinking that?
No,
is that cray or what?
The TRPM8 receptor is responsible for measuring that slight difference in cooling of the eye, and then that's what's responsible for the basal tear secretion. So no, I don't think you're right. You're wrong at all, because you need to get those firing, and I think that that's an area. And then looking at systemic anti-inflammatories as well. and considering that. And this would be the corticotrophin gel, where we look at injections twice a week, about 80 milligrams, and there's a couple different brands out on the market right now that are injectable, and the patient does it at their own home. They're given all the instruction. But these are patients that have failed. These are patients that are frustrated, and you're trying to take care of some of that inflammation. I don't know, are you using corticotrophin gel?
So unfortunately in Arizona, we have to go through an ophthalmologist.
Right.
So it makes it more challenging, but we have schools in there. And, if I could just, digress for a second, a lot of the things we talked about, you may not have them in your practice. And I think what's beautiful about optometry is that intra-optometric referrals is what we should do. I mean, we saw 3 phenomenal clinicians that joined us today, and I know that any one of them, a referral within their town or even out of their town. I mean, Cory is all referral, and Lindsay and both Mitch both work in more of a surgical ophthalmology setting that takes a lot of referrals. But what the few patients that I've had who've had chronic iritises, who've had neuropathic discomfort, the corticotrophin gel has been phenomenal. I know you have been using this for a long time, even on your NK patients, or
yeah, actually, patients that I will have NK that actually didn't heal from the nerve growth factor, and then I'll put them on corticotrophin gel would be the next step.
And again, you have 2 companies, I think, that are selling this that are working with you and your patients to really make this manageable. So these aren't pie in the sky, oh my God, I can't. These are really opportunities for us
and
to
even
co-manage.
if the state doesn't allow to prescribe that, you could work with the ODs in those referral centers that can get it.
Right.
Because that's essentially what you do, what I do within that. And it's just a means of saying, okay, we're going to refer to look at a really, really high level treatment to be able to do that.
I think, for me, I really feel that, ocular surface pain or corneal nerve sensation is the tip of the iceberg.
Yes.
Because as you had mentioned before, Doug, too, is that, there's an anesthetinometer that can be, hopefully, will become a lot more obvious to us, and we get more objective measurements, be able to determine where somebody is on the spectrum of discomfort. I know that there's a company that's working on a treatment that can be used in office to try to help with COSP. So I think we're just on the cusp of some new opportunities, because when patients feel better, then everything's better, So
To that point, Mark, I do believe that corneal nerve health is the future of eye care, because we see that in many different entities that corneal nerve health will decrease. So what if we were able to monitor that with a contact lens patient by having a quantified and objective and repeatable measurement to do that? Would become part of a routine exam, especially if there was a code for it. But that would be monitoring the health. What if you were able to tell your contact lens patient, I'm going to monitor your corneal nerve health, and when we start to see something, we can take earlier treatment. We can do nerve growth factors. We could do...
Doug, it's what we do with osmolarity, what we would love to do. It's what we would do with IOP. Imagine now if you get an assessment of somebody's nerves. I mean, so it's like the simple things we can do to add to our evaluations that help our patients immensely. It just, I totally agree with you.
Yeah, and that's what we need, is the
spot on.
quantifiable and repeatable.
Yep, 100%.
You know, that a technician can do, and not going in and doing the cotton wisp or not doing the dental floss, but having something that we can actually quantify. And I think that is going to be the future of eye care, because then that moves us into a proactive profession.
Yep.
And right now, we're reactive.
Yeah, totally.
So, so which
Here's our last poll.
treatments?
I think they already answered it.
Which treatments do you currently use? Oh, everybody's answered that.
Yeah.
And we have a pretty good mix, 36% using topical.
Got across the
Is
board there.
the majority of that. So
I cannot believe we made it all the way to our end. We're not going to do a panel discussion. Skip that, because we want to give our patients, time back. We're rolling up on our end of our time here. Does it feel like we've sat here for three hours? I don't think it does. I don't think it does. Well, it doesn't for you.
2 hours.
It doesn't for you, because you're not sitting in a pool of your own. Hey, we have some questions. All right. So what's our first question here? Okay. Inflammation feels like a general issue. I can't really control it. How much can current treatments really impact inflammation today? Doug?
Well, what we have today is we really do have the ability to control inflammation. I mean, if you look from the steroids to the immunosuppressives, we can really have a start at controlling it. But then we have to modify some underlying factors.
Yeah.
And modifying some of those underlying factors could be nutritional, they could be environmental, they could be something like inadequate lid seal that is driving a lot of that inflammation and that breakdown of the tissue. So I think what we have is we have a really good start to be able to control it. Can we cure it? That's where we have to find the root cause.
So I would take one step further then and just say that, look, we're managing conditions. We're not going to treat it. So I love to tell patients, look, there's no way I'm going to have you stop using your computer. There's no way I'm going to have you stop staying in air conditioning. But what you can do is what you said, Doug, is you can modify things. I loved hearing, Lindsay talk about doing blink exercises, and more importantly, talk about, when we heard Cory talk about using nutraceuticals, leafy vegetables, modifying your diet, that whole caveman diet or paleo, or I think, is it paleo? I think it's caveman, one of those diets, to kind of talk to patients, because you're their clinician. They're going to listen to you. Vision is so important, and I think that you can't pull back from not talking about the things they need to do. But at the same time, why I like the using immunomodulators or using something like perfluorohexyloctane is because I'm telling patients, look, you're never going to get rid of this, but what we can do is kind of slow down the progression.
Yep.
What's the next question, Doug?
What are the key signs you look for when diagnosing Demodex blepharitis? The key sign is having the patient look down and look for the form, and even if you have to increase the mag, looking for collarettes around the base of the lash.
For me, that's the simple one. I love that low-hanging fruit there, my friend. But I walk into the lane and the first thing I look for is rosacea. If I see red ruddiness to the cheeks and nose, boom. If I
Which
see
you're going to see on your male patients, but not on your female patients.
I know. My females, I'm looking for the pores, okay? I'm looking for the big pores. I'm also looking at little telangiectasia, little rosacea type inflammatory markers on their lids. Makes me gravitate towards looking for things on their lashes, loss of lashes. Anybody that's wearing lash extensions, I'm thinking there's got to be maybe something underlying there. Looking for tented up lashes, so it almost looks like they're kind of pulling. And then also Laura Perriman describes something that she calls the alpenglow sign. And if you go from your eyes, if you stop your slit lamp right in the bridge of the nose, you'll see these tented up little hairs that are just vertically coming out. And she's actually evaluated those and found that they're full of brevis. So they're full of Demodex mites. So key signs, obviously, the number one is looking for the collarettes, but also there's other, as Doug described, non-obvious Demodex blepharitis signs. Yep. Do you have time for one question?
Can you address the CLIA changes associated with MMP9?
No, I can't. Doug, can you?
I think that most of the changes are state by state, because there's the federal CLIA and then the states have their own pharmacy laws.
When that person said CLIA, I thought it was like Cleon. How many people are watching Foundation? All right, never mind. So,
what is the right omega-3? Well, actually, what I use is an omega-3, omega-6 combination.
Yeah.
That's what I found very successful, using something like black currant seed, gamma-linoleic acid combined with omega-3. Very tolerable. Patients can't replace it. They can't come up with a substitute, and found very, very good efficacy with that.
All right, kids, we're almost done. We're going to go back to our polling, and then you guys are free. You get the rest of your Sunday free. I don't, and neither does Doug. But we're here for you, people. So here's our first question. After attending this program, rate your level of confidence in your ability to differentiate, classify ocular surface categories, disease severity, including aqueous deficient and corneal disorders. I'm waiting for my friend out there, waiting for my 20%. But look at that. Most, if not all of you, are very confident somewhat. What's our next one,
Good
Doug?
progression. Based on what you've learned today, what percentage of your patients do you now believe have Demodex blepharitis and MGD? 0 to 10, 11 to 25, 26 to 50, or greater than 50%?
Yeah, I think there's a huge correlation. I'm not trying to skew the numbers, but I mean, if you're not going C or D, then you're missing out.
Yep, there we
That's
go.
what I told you.
C&D, we got it.
It's all about the moons circulating around Jupiter.
Jupiter,
Totally.
not
Great,
Saturn.
Great study.
After attending this program, rate your level of confidence in your knowledge of current treatment protocols and integrating patient-specific factors for Demodex blepharitis.
Oh my God, I feel super confident.
Very confident.
Yeah.
I think we're-
I feel super confident. Look at you guys.
Wow.
Look at you.
Slam dunk.
Look at
100%.
you. Look at you. Look at you. Okay.
Good response on that.
Rate your
Very
level of
confident and
confidence.
somewhat
Oh, sorry.
confident.
Rate-
After attending this program, rate your level of confidence in your ability to diagnose and treat patients with MGD.
Yeah, I mean, I'm still probably going to go with very confident. That's where I'm going with that, Doug. But you be you, boo. You guys decide. Yeah, because I love that. Thank you for being honest, people. Somewhat very confident. Excellent. All right.
Okay, moving on to the next. After attending this program, rate your level of confidence in identifying patients with neurotrophic keratitis. Now, we saw what those numbers were originally, so this will be very interesting. Hopefully, look at
Yeah,
that.
there we go. Somewhat very confident. You guys are killing it.
Yep.
What do we have, like 30 more questions left, Doug? How many more questions?
Yeah, that's all. After what you learned today, how confident you are in differentiating between cyclosporin treatments, so this is a good one,
Yeah.
and your understanding of maximizing patient comfort and tolerability with these treatments. So we've really hit on the cyclosporin treatments today.
Well, I mean, there is a differentiation between the 0.09% nanomicellular and the 0.1% with the perfluorobutylpentane. So, very
Well, based
good.
on that, it looks like the highly confident and somewhat confident are the ruling factors, 60%
Yeah.
on somewhat confident and 35%. So that's
I think the more we talk, the less confident people feel. So we got to
so
shut
we
up
better
and
just
move
keep
on.
on moving on. to that. After attending this program, how often will you recommend preservative-free when drops? Oh, this will be a good one.
Yeah.
Patients for dry eye disease. Preservative-free, how many? I'm going to quit at that one.
Yeah, I
I've got 100%.
Well, it's funny because I never was always. Okay? I never was. But now I am. So,
Okay.
awesome.
Good, good. Well, we got always
All right,
often
we got
and
sometimes.
sometimes.
All
so.
right, all
Okay,
right,
we're
all
on to
right.
our
This is our
last
last
question.
question.
And then, based on what you've learned today in this program, please share one action step that you plan to implement in your practice.
Okay. Preserve. Okay.
Prescribe
Utilize the dry
preservative-free drops
questionnaire,
for most
perform a lid
patients. Utilize the
exam,
dry
add
questionnaire.
one new therapeutic.
Perform a lid exam during every
I plan
patient
to
visit.
implement more than one. I think I'm going to go with E.
Add one new therapeutic protocol based on the research and developments.
Yeah.
I plan to implement more than one. What do you think, Mark? Look at that.
More than one's rolling. There we go, man. I
We're
totally
doing-
appreciate that.
We're doing
Doug,
pretty good.
as always,
It's a pleasure.
it's a pleasure.
We had a lot of fun.
Want to thank our sponsors for their unrestricted educational grants, which basically means that we got to use it for wherever we wanted. I'm not going to share with you what Doug and I did with that, but thank you guys so much. It's been amazing, and hopefully we'll see you guys back next fall.
And the
when
next series that we do.
Oh, this is summertime. Oh my God.
It's summertime, so,
our next
yeah.
series. Great.
Thank you so much for tuning in today.
Advance to the last slide. There's one more slide. There it is. Yeah, it's us. Try some. Thanks, everybody.
Thanks a bunch. Bye-bye.